progress and knowledge, but more importantly, our friendship. Thank you again to all the participants. As IWG's International Working Group on EES, we have been organizing biannual World Congress, speaking at various international conferences, and sponsoring hands-on seminars held around the world. Today, we have the first IWG's fall webinar, which is on global perspectives in cholesteatoma. I'd like to thank Arun, Manuela, and Adrian for organizing this fascinating webinar. Now, there is no time to dawdle. Let's all attack the topic of Raiders of the Lost Ear. Thank you.
Thank you, Seji. So I think the next item on the agenda is challenges in starting endoscopic ear surgery practice in Indonesia by Diana Rosalina. Diana is a consultant ENT surgeon and otologist. She is based in Indonesia, in Jakarta, and she has got a lot of experience in endoscopic ear surgery, and I've been meeting her in various congresses for the last few years. And she is currently working as an otology consultant at the Indonesia College of Otolaryngology and Head and Neck Surgery. So, Diana, I invite you to give you a talk now.
Thank you. I will share the screen. Can you see my slide?
Yes.
Okay. Hello, everyone. I'm Diana Rosalina from Jakarta. Thank you for having me here. It is my honor to be part of this webinar and greeting from Indonesia. I will share our challenges of starting endoscopic ear surgery practice in Indonesia. I will bring you from Europe, crossing the Atlantic Ocean to the USA, and then fly over the Pacific Ocean, and this is Indonesia. Indonesia is a developing country in the Southeast Asia. It is the biggest archipelago country with the fourth largest population in the world. It consists of a 38 province with Jakarta as the capital city of Indonesia. Today, we have around 1,800 ENT doctors, but only 10 to 20 who perform ear surgery, mostly caused by limited facility of microscope. Ear surgery mostly performed caused by chronic suppurative otitis media with 3.4% in prevalence, or we have about 10 million cases, or about 10% of cases in the world are here. Otology Study Group of Indonesia identified some problem from the census in 2070. We found it's only 100 ENT doctors perform ear surgery. In 2016, only 2,900 CSOM from about 4 million cases underwent surgery. The spreading of the ear surgeon is not equal, dominantly in Java Island, as the capital and a big city are located. Even the Borneo or Kalimantan Island, as the third biggest island in the world, that its size 3 times that UK, has not more than 10 surgeons. Our hospital system is divided to be 3 types. Type A is the highest referral hospital that mostly facilitated by microscope, endoscope, otology instrument, including EAS instrument, but the waiting list for ear surgery is more than 6 months in average. The type B and C have less facility, especially microscope, where the most of our ENT doctors are work. Meanwhile, the endoscopic equipment are available in all of the hospitals. What we have done for EAS. First, we learn from the expert of the endoscopic ear surgery. And then we also held the national or regional conference or lecture about EAS. We held the EAS dissection courses. We've made the video of EAS dissection in Indonesian language. And we fly traveling Indonesia to develop EAS skill and competency to reach many places. And last, we have put endoscopic approach as one of surgical options in our national guideline for CSOM. Dr. Sukin met with the earliest Indonesian surgeon who learned EAS from Dr. David Fontier in Toronto, Canada in 2008. And many Indonesian ENT doctors exposed with EAS after the 9th International Cholesteatoma Conference, Nagasaki, Japan in 2012, and First World Congress of EAS in Dubai in 2015. After that, many courses were attended by Indonesian delegates around the world from Thailand, Singapore, Yamagata, Hong Kong, Dubai, Malaysia, Boston, Sydney, Kyoto, Italy, and many more. We also participated in the World Congress of Endoscopic Ear Surgery last time in Kyoto. We held a national and regional conference with EAS topic to discuss by inviting leaders and members of International Working Group of Endoscopic Ear Surgery. We also emphasized and developed the competency in reading CT mastoid for patient selection for EAS. 7 universities and 1 hospital in Java and Sumatra Islands has had the EAS dissection courses since 2014 until now. The first EAS dissection course in Indonesia was guided directly by Professor Muastarabici in University of Padjadjaran Bandung in 2014. Followed in Jakarta, Malang, Padang, Semarang, and Surabaya. Professor Muastarabici, Dr. Baritan, Dr. Raymond Ngo, Dr. Philip Rajan, and Professor Insekmun had visited us in teaching EAS dissection. Our priority is using fresh cadaver, but it's not always easy to provide. So we also use a dry temporal bone with skin and ovine for EAS dissection. We also use my fit ear phantom developed by University of Brawijaya for the simple endoscopic procedure in eardrum. Indonesia Otologic Study Group also made a video of EAS dissection in Indonesian language for a better understanding of endoscopic ear surgery. Travel across Indonesia in social community service is a routine activity organized by Indonesian ORL Society and Otology Study Groups in 2007. Despite of helping poor patients, we also use this activity to increase the competency in ear surgery, including EAS, and to achieve wider coverage of nations since 2016. We perform EAS live surgery and supervise the procedure for novice surgeon. We teach how to select patients for EAS based on the clinical manifestation and CT mastoid. And last week, we've just come back from Palu in Central Sulawesi for this activity. In 2020, we've made a survey involving 300 ENT surgeons. We found a significant increasing number of ear surgeons under 7 times who performed a tympanoplasty endoscopically in 5 years. With type 1 tympanoplasty is the highest procedure, and almost all respondents were interested in developing skill in EAS. Our national guideline of CSOM in 2018 has mentioned about endoscopic ear surgery as part of procedure in CSOM, so national insurance will cover the procedure. And next event in this year with the EAS topic will be held in Malang starting tomorrow and next week, and in Fatmawati Hospital where our work on the next will be on the next November. And the bigger event will be held in 12th Otorhinolaryngology International Academic Conference, or OLIAC, in conjunction with the 13th Indonesian Annual Otology Scientific Meeting, or PITO, that will be in Denpasar, Bali, one of the most beautiful islands in the world. And on behalf of committee, we invite and welcome you to join this event. It will be great because we're planning that Professor Nirmal Patel and Professor Daniel Marcioni will give a lecture online, and Professor Shao Nogueira will be here and perform live endoscopic surgery from Sanglah Hospital University of Udayana. Hope we will see you soon in Bali next month, and more experts of IWGEES member will come here and help us developing EAS and ear surgery service in Indonesia. Thank you.
Okay, so I think that is short and sweet, and it gives you a perspective of how the technology can help in in such a diverse, difficult area where microscope is not always available or easy to transport. And so it's a wonderful talk, and I hope that you will have a very successful meeting at Bali. Thank you. So
Thank
the
you.
next speaker is Chung from Hong Kong. She is going to talk about how endoscopic ear surgery changed her practice of otology. Waitsi is very enthusiastic, and she's very much part of the scene in various meetings. I first met her at the World Congress in Italy. Waitsi is an assistant professor in the Division of Otology and Neurotology at the Chinese University of Hong Kong. And also, she's an honorary consultant at the Prince of Wales Hospital in Hong Kong. And she has published various papers on several aspects of endoscopic ear surgery. And one of the most interesting things that I remember is her chopstick technique in endoscopic ear surgery. So, Waitsi. We can't hear you. Are you muted?
Okay, can you hear me now?
Yes, yes.
Okay. Thank you, Arun, for inviting me and have this opportunity. So today I would like to share with you how EES changed my otological practice. Actually, I am not that super young, because when I was a
Sorry, we missed, we can't hear anything. Sorry, we can't hear the audio. We can see you. Is it muted? No.
Wait, see, it says on the screen here, I can see there's a red line through your microphone button. So somehow the microphone's got muted again.
Yes.
let's try. Hello, hello.
Oh, that's good.
Yes, yes, good.
Okay, sorry. So I am, can I start again? Okay. So today I would like to share with you my how EES changed my otology life. So actually, when I was a medical student, my first experience of ENT or otology is in Africa. So it's a very poor country called Swaziland, and now Eswati. And there was no microscope, no endoscope. They used tristle and gouge. They used the headlight to perform myongotomy or even mastodectomy. But when I was a trainee, I was trained under microscope. So all my otological operations was trained under microscope with cholesteatoma and myongoplasty. Or every one of them told me that, oh, this is the gold standard. Not until 2015, when I was still an ENT resident, I started my endoscopic ear surgery journey in Singapore, that I met two masters, Macchioni and Saiji. So in Raymond's course, this is what I saw, the sinus tympani. So before I was thinking about sinus tympani is very difficult to understand, with different books, different techniques, different skills. It's very difficult to imagine and visualize, because the facial nerve, the stapes, tendons are hiding these important structures that we are impossible to visualize in memories. But with an endoscope, without any efforts, we just be able to see it. It's just in front of our eyes with a 0-degree endoscope. And how clear is the anatomy in the middle ear when compared to the microscope. So as you can see here, you can see this is the hand of malleus, this is the chorda tympani, and now this chorda tympani is huge, and it's not obscure the stapes by the malleus. The long handle was missed, and here in the microscope we can't see the round window. We can see the high writing jugular bulb just with a 0-degree endoscope, but in here it's very difficult to appreciate. So when I come back and then I started with a practice while using a very traditional, very old endoscope with lower qualities that my boss at the time did not allow me to have a good one. So I just steal all the nasal endoscope to try to operate on my first few patients with a simple operations. But all of a sudden, there's my Professor Tong told me that I got a case, and this patient has a peaches apex cholesteatoma, and he don't want any incision outside the ear. So this is a perfect case to start your endoscopic general anesthesia surgery. I was a big surprise. So we study hard, and then they said, "Oh, you start with the chapter 15 of the AES book, but not the chapter 1." So eventually we operated together with a lot of struggle, of course, as initial starters. We successfully removed the apex cholesteatoma, just Chung's canal. And this is immediate post-operation view that the patient does not have an external wound, but the post-operative 2-3 years MRI surveillance didn't show any recurrence. So this gave us a lot of courage that actually it is possible to practice endoscopic ear surgery. So since then, I perform almost all the middle ear surgery, laryngoplasty, ossiculoplasty by using an endoscope. With more practice, I got better skills and better handling of all the small techniques. And then including staphydotomy, I actually don't know how to perform a staphydotomy with a microscope at that time, but I started with an endoscope, and it precisely allowed me to visualize all the details and all the small movements of the middle ear. And then, of course, cholesteatoma. So this is a very typical atic cholesteatoma, and it's very good for endoscopic removal. There's no mastoid involvement, so I was told, oh, okay, so this is the best case of cholesteatoma to use endoscope. And this is really without any a lot of bone removal with not much drilling, we'll be able to remove all the cholesteatoma. And now we thought that with the microscope, we remove everything. But in fact, give a magnification and closer look, we can see there is a small layer of squame covering the stapes footplate. So this is how endoscope can allow us to have a very detailed examination and dissection of the cholesteatoma. So another very important change is the ventilation concept. Before we were told that we have open cavity, we just lay open everything and make a big meataloplasties. But no, if the patients have a very good mastoid, very ventilated mastoid, we can actually look at the TensorFlow, we can actually look at the ventilation system. And therefore, it made me a habit of checking the ventilation system for every single patient with a good aerated mastoid to check for the TensorFlow. And also, we use a 30-degree endoscope to check, have a panoramic look of the middle ear and the mastoid. After all the cholesteatoma surgery, it makes a habit of mine. So this is very important steps. Since then, we have a lot of courses held in Hong Kong, and we have a dissection menu. At that time, in 2016, and we called TEES, T-E-E-S, Total Endoscopic Ear Surgery. We are so into the endoscopic ear surgeries that I think everything can be done by endoscope. But in fact, we face difficulties. The drills doesn't work well, and actually with a very big mastoid cavity, using an endoscopic approach, the drill is super slow, and we have very long operation time if the cholesteatoma is unexpectedly long. And when I was confusing, I have another fortunate to attend an overseas fellowship to Marisana and a very endoscopic surgeon and Macchioni, and I thought they're fighting with each other because the endoscopes that have a lot of advantage. The microscope said Sky said, just 2 hands operations, more effectiveness, more efficient drilling, it's very fast, we have 3D images. So endoscope is not going to help. But in fact, they are actually complementary each others. So I stepped back to do more microscope than before. So Michael, my boss, also always say that I am the one who trained endoscope and then backward the endoscope, but backward the microscope. But in fact, the bone drilling is much faster with the microscope, and this is what we thought. And also we have invented different techniques to overcome the challenge. For example, single hand operations, we have chopstick techniques, we can hold the instruments and also the lasers, suctions, etc. And we have underwater techniques to dealing with complications with the endolymph. For example, the cholesteatoma eroded of the foot plate of the stapes, and then we use underwater technique. We'll be able to examine without injury to the inner ear fluid. And also here is a dehiscent facial nerve with a cholesteatoma just on top of the foot plate. We are unsure of the integrity of the foot plate of this little girl. So eventually with underwater technique, we'll be able to remove all the cholesteatoma, and we'll be able to visualize the foot plate, and we're sure that it is intact, and then we can clear all the cholesteatoma from the foot plate. And then we can overcome the boundary of the middle ear, anterior, posterior, inferior, and medially. We can combine the microscope and endoscope together, view in view with different surgeons. And nowadays we are combining the exoscope and endoscope with no hazard and no hesitations, especially during the COVID era, the bone dust will not affecting us as much. And extended use of transcanal wound would be more useful. Apart from cholesteatoma, we can even extend the use to different areas of the lateral skull base. And nowadays, if we have a cholesteatoma with the extension to the mastoid, then we can use the transcanal wound, and through the microscope, we have performed the drilling till the very end of the cholesteatoma, and then we can change to endoscope in order to have a better look with an angled view. Using angled instruments, we'll be able to use a relatively smaller amount of bone drilling to completely remove the cholesteatoma with evidence and make sure it's clearance. So we are now combining the use most of the time endoscope and microscope, including the very infratemporal fossa cholesteatoma that go down, affecting inferior to almost to the level 2 regions. And we'll be able to use the combined microscope and endoscope, and underneath this mastoid portion facial nerve down to the submastoid foramen, we're able to remove all the cholesteatoma, and with the endoscope we can go inside. So this is the carotid. We can see the pulsation of the carotid at level 2 and make sure that the clearance of. So this is the carotid, the clearance of the disease. So in overall, we have performed a lot of transcanal surgery at the lateral skull base, and most of them are cholesteatomas, you can see. So in a result, it's a very good result that only 6 patients has a wound infection of that wound, 2 patients with wound dehiscence, and there's no case of postoperative CSF leak or intracranial hemorrhage, and there's a mild stenosis. So I'm not going to show you this case because lack of time, but in conclusion, I think endoscope offers a very new insight to otological surgeries. Transcanal is a safe option, and combining endoscope and microscope or exoscope, even robots, do not limit our thoughts, and be open-minded, be very creative. Then we have a very good and bright future, and head-up surgery is our future. So with that, thank you very much.
Excellent. Thank you very much, Vaitsi. That's a fantastic presentation. I'm sure that the audience will have questions, but what we are going to do is ask them to, in the question and answer session, and we will address them at the end of the session rather than in the middle. So without further delay, I think we'll go to the third presentation, which is the traveling to Kenya and endoscopic ear surgery by Alessia. Alessia Rubini is from Italy, and she's working with Professor Marchioni, and she's graduated from the University of Verona, and then she was trained under the tutelage of Professor Marchioni. She has also visited various centers of excellence all around the world, including visiting Manuela and Toronto to see Adrian, and Sydney, and then to India as well. So let's hear from Alessia about her experiences in Kenya.
Thank you, Arun. I think I have some problem in sharing the screen.
You have to first of all open the presentation in the background and then share. Otherwise,
Right.
it won't work. Yeah, open the presentation. Go to the presentation mode and then share sharing. Okay.
Desktop 1, is that right? Can you see the
Yeah,
screen?
we can. But what happens when you play?
Yeah, but I can't. Okay. Yes.
Go to the presentation mode. Is this? I think this is not.
Oh, wait. I can do like this.
Yes. Okay.
Okay. Yes.
Yes, that's it. It's not a PowerPoint. That is why people were a bit surprised. You know, it's Keynote, isn't it?
Yes, sorry.
Yes, it's okay.
One of my first time that I'm using Keynote. Sorry. So, good morning, everybody. My topic is traveling to Kenya with endoscopic ear surgery. And I'm going to show you our experience as Italian volunteer of the Endoscopic Ear Surgery group led by Professor Marchioni Daniele. But I can't go ahead.
Oh, go to the next slide. No.
No.
Okay. Why? So maybe come out of the yeah, that
Go like this.
yes, done.
Okay, yes, very tricky. Okay, so first of all, I would like to explain you the ENT situation in Kenya, Africa, because in Kenya there are few ENTs and they are mainly found in the big cities. As you can see in this map, this is Nairobi, and these are all the rural counties around Nairobi. So as you can appreciate, ENTs are rare or almost absent in rural areas. The majority of the patients requiring otology services are rural-based and are generally unable to access ENT clinics because they live very far away and because of the high prices. So rural individuals may have to travel long miles to see an otolaryngologist, making it hard to access otology care. This study proposed how to expand otology services to rural setting in Nigeria. Because in Nigeria, the otology services were present only in tertiary institutions. They found ear disease was the most common reason for attendance at the ENT outpatient clinics, and 45% of the patients with ear disease required some form of surgical intervention, ossiculoplasty, myringoplasty, tympanoplasty, and so on. And most of the patients in the study were found to come from a low socioeconomic class. So they introduced otoendoscopy at secondary institutions, and 1/3 of the patients who required the surgery was considered suitable for an endoscopic approach. 78% of them accepted and underwent surgery in their own towns at a much lower cost if compared to the tertiary institution. So they conclude that endoscopic ear surgery through a portable ear endoscopic set represents a feasible means of extending otological surgical services to rural population that is unable to access urban-based health centers. This is a shipping cost comparison between otologic versus microscopic surgical setup. And although the maintenance costs are similar, the shipping costs of endoscopic otologic setup are much cheaper compared to the ones of the microscope. Understanding this is to be kept in mind both if operate in another country with your own endoscopic set and if it is donated to a hospital with a limited budget. Because understanding the shipping costs of surgical equipment is important for sustainability, because many low-resourced regions do not have the ability to locally repair the surgical equipment. So in fact, a compact and portable endoscopic set is very practical and easy to carry because it turns in a carrying case, and it has a monitor, light source, and it's compatible with either rigid endoscopic and single-use endoscopes. And also there are several brands that produce endoscopic portable set. So we wanted to exploit these advantages of an endoscopic portable set, and we went on a volunteer mission to Kenya, ready to perform endoscopic ear surgery. So the experience took place at the North Kinangop Hospital, which is more than 100 kilometers far from Nairobi. And this hospital began as a health center with only 25 beds. Then it expanded to over 300 beds. Currently, the ENT services are provided by Italian missions every 4 or 5 months, organized by some non-profit organization that grants support from specialists in outpatient clinic and in the operating rooms. So among all the pathologies we examined, 25% of the patients had otological surgical indication, and out of these, 70% were chronic otitis media, mucosal disease, 20% were cholesteatoma, and 10% conductive hearing loss needed exploration. What about the follow-up? The patients were asked to return for an ENT follow-up during the next ENT mission, but unfortunately the follow-up was very difficult in rural areas because only 30% of the patients returned. To sum up, as I explained before, the endoscopic ear surgery has the advantage of requiring a portable surgical equipment. So this way, the surgical otology services could be readily delivered to the targeted population. And also, it has a low transportation cost, and endoscope is a versatile tool that can be used to treat ear, nose, and larynx diseases. But there are some critical points because there are few ENTs in the whole Kenya. And so there is a need for an international charity organization of otologists aiming at operating in rural areas lacking ENT services and guaranteeing continuity. Thank you very much.
Excellent, Alessia. I was hoping to see that picture where Daniele was standing near a lion or something, but anyway. So it's fascinating. And, Kenya is a country where people usually go for tourism and, the animal safari and things like that. But we've never thought about the medical facilities and the problems. So well done. And long may it continue. So at this point, I just want to make an announcement to the participants that if you have any burning questions about the last 3 presentations, please go into the Q&A session and put your questions. Meanwhile, Manuela is going to talk. She's going to show a video about the live with narration on endoscopic management of aortic cholesteatoma. So to introduce Manuela again, she's the backbone of the whole webinar, and she's an associate professor at the University of Minnesota and one of the early uptakers of endoscopic ear surgery in the US. And she's even arranged the first ever endoscopic ear surgery workshop, not practical, but the theoretical aspects and all the other aspects in Minnesota, which was one of the best meetings that I have attended. Thank you. So, Manuela.
Arun, thank you for the kind introduction, and I really enjoyed the first talks. Excellent. So I will be sharing now my screen. Are you able to see my screen fully? Yes.
Yes.
Okay. So I will talk to you today about a case, a clinical case of aortic cholesteatoma that also had tegmen erosion. And here it should start. So here is the clinical case. So we have a 16-year-old young man with minimal right conductive hearing loss and just one episode of ear drainage. He's a competitive swimmer in high school and enjoys water skiing in the summer. On examination of the right ear, you can see that there is a mass in the location of a pars flaccida with crusting that's very suspicious. And the CT scan on axial view, you can start to see that the mastoid is poorly pneumatized, but there's opacification. There's a mass around the ossicles, and there's an extension, as you see, quite lateral in the location of the aortic, not as much posterior. But you also see on axial view how much of the middle fossa dura is visible in this view, while we have simultaneously the view of the aortic and the mastoid antrum, something that you don't see that often. And you can see this outline is now confirmed when I show you. Here you can see also a tegmen tympani dehiscence adjacent to the head of the malleus. So you can see now this conformation of a dural plane on a coronal view, how deep, low line is this dural plane, especially seen on a coronal view, and how challenging this case will be with a mastoid in order to get up to the anterior epitympanic space when you have such a low lying tegmen. I consented the family, and I explained that there would be a possibility that I may have to do even a canal wall down in such a young man. I started the surgery endoscopically. You can see the mass of the in the pars flaccida, making the incision. Here you notice elevating the tympanomeatal flap that I use this cotton soaked with a solution of epinephrine. And you're now starting to see that as I expose, the patient has a very prominent posterior scutum, which most of the times corresponds also to a very prominent anterior scutum. So you see that the challenge of elevating the tympanomeatal flap, you push the tympanomeatal flap, you push it against the anterior canal wall, you have very small space to visualize. We're now finally entered the middle ear, and you notice that we recognize immediately the incus stapedial joint and the stapedial tendon. And the mass, you notice that in part has a pearl-like conformation, but there's also a lot of granulation tissue. It is safe at this point and very important to dislocate the incus from the stapes. And it would be great if this mass would come all as a sac contained, but you can see that the cholesteatoma is ruptured in this area of the aortic. I have also curetted Suctioning, I also find mucus, which is a good sign because it means that there's mucus in the mastoid. After dislocating the incus, at this point, I need to remove the incus because there's not enough space to remove the mass in block with the incus. And I have a good exploration of the middle ear, that the stapes is intact. We can see the facial nerve in its tympanic segment. And at least we can see that there is a single layer, a capsule of the cholesteatoma. We need to extend the athecotomy. There was component anterior to the malleus head, so the malleus head has to be transected with the malleus nipper at the neck of the malleus because there's still component anterior to the malleus head. At this point, we do utilize angled scope. This is a 30-degree view. You can also use a 45-degree view. And I had to enlarge the athecotomy. I do utilize a piezoelectric drill. To enlarge my athecotomy, there's a fine balance we'll discuss later about too much of an athecotomy and the exposure. But this was necessary to see the most superior aspect, how much, because there was that extension and that extension up to the tegmen. Here you can see a slight pulsation in the fluid because we have this area of tegmen erosion and dural exposure. However, we have now a clean field. You can see the relation between the tegmen tympani area because that's the location where the head of the malleus was. And now you can see look at this tiny little perforation. That's where the cholesteatoma started this process, the primary acquired. You will not see very well, but when I encountered this, I cut into that perforation and open it up and marsupialized because otherwise you can have skin still growing. Now I elect in this case to reconstruct primarily utilizing its own incus and performing an incus interposition graft between notching it between the capitulum of the stapes and under the handle of the malleus. I felt pretty good about the cleaning, and I thought that it was important to give him a primary reconstruction. The cartilage grafting is a crucial part of the operation. You can see I intentionally leave the cartilage graft very thick. It has to have a tight fitting. You see there's a small gap. We cannot have these small gaps. So I use wedges of cartilage to make sure that it closes perfectly. Otherwise, you will have epithelium retracting in there. We use double layer, placing an additional layer of perichondrium to cover everything. The flap is placed back and the little perforation is not well shown, but it is cut open. And in order to open up that tiny perforation where it originated. And then we have gel foam the first gel foam, I like to place them dry to create a glue-like effect, and then antibiotic soaked. 1 month appearance. This is the appearance at 3 months. The cartilage is nice and stable. 1 year post-op, the cartilage didn't budge at all. And we had a MRI with DWI at 14 months negative for residual disease. We are planning a second MRI at approximately 2 years. And the hearing test shows good maintenance of his air conducting threshold. Thank you.
That is excellent, Manuela. I think you've shown the necessary steps, and I'm amazed that how it looks after 3 years, and it's perfect fit. Later on, we will hear from Adrian, and some of the pediatric cases is never going to be that easy. But let's now move on to questions. Okay, so okay, the open questions is okay. There is a question to Alessia from my friend Mondio Morgan. He's asking, in the interest of sustainability, is there any suggestion to include the training of the local ENT surgeons in wherever you are? And
Yes. Yeah, right. We would like to organize the endoscopic ear surgery courses for local ENTs, but the problem is that in secondary institutions there are mainly general surgeons, and while ENTs are only in the big cities in Kenya. So that is a problem because otology surgery is very specific, and it cannot be taught to a general surgeon. But yes, in the big cities, it is possible to arrange some endoscopic ear surgery course.
Okay, so I think that's very good. As you say, at least even if you arrange it in the bigger cities, the problem is the availability of the endoscopic instruments and the cadaveric materials, and maybe simulation may have a role to play here. Using animal models, for example, lamb said, I know Livio Prosuti has done some studies. I have published a study on comparing the anatomy as well as the usability of lamb said. Maybe these are the sustainable issues, but whatever you guys are doing in Kenya is commendable, and I hope that it will continue, and we all may be able to participate and help in the future. Indeed, Daniel invited me last time, but that time it's not suitable. So there is not many questions from the audience, but I will have some, questions. So Diana, one of the questions I want to ask is, the problem with Indonesia is so many islands, and it's so widespread, isn't it? Until I had a chat with some of your colleagues from Indonesia recently when I was in Korea, I never realized the breadth of the country. It's huge, but the problem is there are several islands. So what sort of, what can you do to sort of improve the care? Do you think it is a hub and spoke model where some of them are diagnosed and sent to secondary or tertiary centers, or or each island should have some of the endoscopic ear surgeons or otologists, and then difficult cases are sent elsewhere? What is the model currently, and what is the sustainable model?
Okay, even we have a wide location in Indonesia and island, we divide in 38 provinces. And in each province, there is a center of a hospital. So, and in our organization is very supporting in ear surgery development. So we, since 2007, leading by Dr. Sukin Mansukin, we traveling a lot to develop each area. So we develop we perform this surgery in the center of a province, not in the rural area like in Kenya. So we develop and we facilitate, and sometimes we bring the endoscopic and supported by the company, and also we brought the instrument, and then we arranged many surgeons from other area to come to the place. And we hope with that we can make many surgeons will be interested to improve the ear surgery development. And so we also encourage every surgeon in this area to collaboration with the local government to support the facility, and so we can improve together the ear service in every place in Indonesia. I think organization is very important to accommodate all the problem.
Excellent. So I think, yes, the other thing is that because we are thinking about in a greener world, and if you're going to move the patient from airlifting or something, that is going to be more problematic, but your model is working reasonably well, and so that's a good model. But regarding that, I got another question from a resident in Indonesia asking, how would you address your learning curve regarding otology patients? Can you share your learning experience, or is it better to start with one-handed endoscopic ear surgery or microscopic surgery? That's a very interesting question. I will first of all say that I published my own learning curve in just laryngoplasties. It was a bit embarrassing, but I thought that, I'll have a look at it. Initially, the first cases, I selected small perforations, posterior perforations, and the first 10 cases, fantastic. Almost all of them healed, and I was very happy. Then I started doing it for all the cases. Boom, the success rate went to 65%. And it was embarrassing. And then we couldn't understand why. And then we looked at various things like, the meticulous dissection, supporting the graft medially using some materials, or even releasing the tympanic membrane from the handle of the malleus and putting cartilage graft, like a Pac-Man graft, onto the handle of the malleus. Then it started improving. And the next 30 patients were, it became 75 to 80%. But in the end, when we looked at it in the last cohort, it was again more than 90%, which was better than the microsurgery. So it is my own experience, which is published, but I would like to hear from anybody, any of the faculty, an answer to this. I'll break into two questions. One, is it better to start with microscope or endoscope? That's the first question. So who would like to go first? Manuela? You're muted.
Well, we have to see, basically, sometimes we don't have a choice, in the sense that for us, our generation, we trained with a microscope and then we transitioned to the endoscope. It was a favorable thing to me because at that time I was still keeping my otology. I wasn't able to have the perfect otology practice. So I was doing still a lot of sinus surgery and other head and neck cases. So I was very comfortable with the endoscope. However, in our residency program, we have this combined training where we have attendings that use primarily the microscope for tympanoplasty and endoscopy. And so the residents learn at the same time. So I think it's really a question of times and the training for the trainee, probably simultaneous learning in the sinoscope. There's no, you should train with both, basically.
Okay. So, what about Vaitsi? What do you think?
Well, if you ask the trainee nowadays, I think most of them prefer an endoscope because you see middle ears so much clearly, but they cannot abandon microscope. So I would say I agree that we have to learn both. But if to start with an anatomy, it will be easier to understand with an endoscope. So if I have a trainee to start, I will teach them with an endoscope first. While they are familiarize themselves with the middle ear anatomy, then I will ask them to try on the microscope, especially when there is bone drilling or mastoid surgeries, and I encourage them to use the microscope or exoscope.
Okay. And any of the other faculty? Adrian, do you want to add anything to this?
I would agree with Waitsi and Manuela's perspective. I just had one extra comment to make, really, that your comment, Arun, made me think is that techniques that we learn with a microscope aren't necessarily directly applicable to techniques that are good to use with the endoscope. So there are differences with a one-handed technique, and yeah, learning both is so you can learn both simultaneously. I think is what happens in our program, really.
Excellent.
Oh yeah, when you see how they change when they use the endoscope, and then suddenly you ask them to use the microscope, they still kept using only one hand.
Yeah.
You have to remind them you have another hand to use.
Mm-hmm.
Okay, so Muas, anything to add?
Not really. No, this was great talk from everyone. Yeah, I agree. I'm interested in Adrian's comment that, to me, the surgical objectives are the same, whether you're using the microscope and the endoscope, and depending on the task at hand, you could probably accomplish one better than the other. So, but I didn't understand Adrian's comments about the fact that almost you have to change your whole technique around the instrument.
Yeah, so I had a similar experience to Arun, is that when I started doing endoscopic tympanic membrane perforation repair, I tried to do it the same way as I had done with the microscope. examples of the difficulties I had were using temporalis fascia with one hand is difficult because it's stuck to the Rosa needle. It's stuck to the instruments, and when I tried to do it with perichondrium using the technique that I used with fascia, the perichondrium wasn't big enough and didn't reach from one side of the ear canal to the other. So my normal techniques that I'd used before didn't really work. And my success rate initially was not so good, I think, because of those kind of challenges. And then I learned different grafting techniques. I use now predominantly use, well, I'm not so sure if we're supposed to use trade names, but a porcine derived, semi-synthetic graft. So I don't have those issues. So yeah.
Okay. I think there's one more question before we move on. It is for Manuela. Manuela, the question is, how would you keep the incus stable in incus transposition using one hand? That's one question. And was the postoperative audiogram good?
So if a question was about how do you position the incus with one hand, I hold it with a very small suction. I let go in the position and I want it, and then I try to advance it with a Rosa needle. If a question was how do you keep that incus stable, notched between the stapes and the malleus without putting any gel foam around, it is because of the height of how you sculpted your prosthesis is that height where you almost have to, it's tight. Once you get on the gland, a little notch you created over the stapes, you place it on, and then you almost have to lift your malleus handle to make advance the incus and kind of snatch it in place. So it's very firm. It should be very firm. Hope I answered the questions.
Excellent. So I think we are on time. And so unless anybody else has got any comments, we can move on to the next the item, which is the panel discussions. Okay, this is important part of the discussion. So the next panel is on scutum reconstruction and recurrent cholesteatoma, and the moderator for this is Adrian James. For those rare people who may not have seen Adrian, he is one of the pediatric otolaryngologists based in Toronto. He's got a huge practice, and he is also meticulous in recording his results so that he has a wealth of experience that he can hopefully share with all of us. And Adrian, do you want to introduce your panel members, or do you want me to do it?
Yes, I'm happy to do that. Thank you, Arun.
Okay, thank you.
Excellent. So first of all, thank you to Manuela, and especially Manuela, but also Arun for doing all the work in organizing this meeting. And as Arun says, Manuela does always organize a fantastic meeting. So thank you, Manuela, for all the work you've done. And Arun's done all the technical organizing behind the scenes. So thank you for that too. Actually, my involvement was very small. In some of the sort of early discussions, I proposed some topics, and very selfishly proposed the topic that I wanted to know the answer to, which is this one about scutum reconstruction. Manuela showed a very nice video of an atocotomy, which is of course a fundamental part of endoscopic cholesteatoma surgery, and your reconstruction looked very easy, but I must say you made it look very easy, Manuela. Sometimes I think it can be very difficult to get the cartilage to fit well. And so I am delighted to be joined by the perfect panelists. You guys were my first choices, so thank you all so much for agreeing to participate. Brandon Isaacson is a professor at the University of Texas Southwestern Dallas, has been doing endoscopic ear surgery for a long time. And I know you're a good surgeon, Brandon, because having done an endoscopic ear surgery course, the very next day you became a totally endoscopic ear surgeon. So, and I think you were sort of yeah, you obviously had the dexterity to pick it up quickly. For many of us, especially me, it takes many years to get to that point. So, and I always appreciate your thoughtful perspectives on things. Professor Nirmal Patel works down in Sydney and is a founder of the Sydney Endoscopic Ear Surgery Group, which I think is one of the world leading centers for helping promote the technique now. Has beautiful, I think you guys are great teachers down there and always lecture well and have very nice videos available through your website for educational purposes. And you're always very thoughtful, Nirmal, in your answers as well. And then finally, of course, Muaz Terabici, who everybody knows is the founder of Totally Endoscopic Ear Surgery. Muaz has, of course, well, the biggest experience in the world in this area. And so I'm delighted, Muaz, that we can benefit from your experience in this area as well. So what we're going to do is, first of all, I'm going to do a shortish talk, sort of just over 10 minutes on aspects of scutum reconstruction, and then I'll have a series of questions to ask the panelists on how I can do things better. And we all know, or at least we think we know, that using cartilage in reconstruction helps to prevent recurrent cholesteatoma, makes the eardrum stronger. And so when we reconstruct the scutum after our aticotomy with cartilage, we think that the cartilage is preventing the skin from retracting in through that defect afterwards. But I must say, I've had experience of cases which really makes me question whether this is true. And so the underlying question behind this session is, does cartilage really prevent recurrence at all? And you can see in the image on the right here, this piece of cartilage was put in to cover a prosthesis, which is doing very well. But clearly it didn't prevent recurrent cholesteatoma here. This hasn't sucked in here for reasons to do with the physiological health of the ear. Whereas on this side, the cartilage is almost perfect. There's just a little gap here above the handle of the malleus, maybe 0.5 millimeter by 1.5 millimeters, and a massive retraction cholesteatoma grew in through this tiny little defect. So I've kind of come to the conclusion really that good ears do well and bad ears do badly. And maybe there are a few in between, which may be good or may be bad. And with good surgery, we can help to make those potentially bad ears into good ears. And so the hypothesis is that if we can do our cartilage reconstruction better, then maybe more of our patients will do well. And so if a good reconstruction does help prevent a recurrence, how can we do that? And that's where I'm going to be looking to the panelists from some tips to help us do that. And so in my talk, I'm going to show you some methods for reconstruction and show you how I prepare the cartilage, show you some of the poor outcomes that I've had, and then see what the panelists can tell me about how to do things better, which hopefully will be educational for all. So this is why I reconstruct the scutum. These are two cases that I inherited early in my practice about nearly 20 years ago. And I thought when I saw these ears, if the surgeon had done an aticotomy, if they'd put a reconstruction in here or in here, these ears wouldn't have recurred and I wouldn't have to be operating on them again. And my training at that point had been to use bone pate for reconstruction. Sorry. It's okay. Sorry. It was to use bone pate for reconstruction. And so that can do a nice job. You see the bony reconstruction here. Sometimes it fails, it's not always perfect. But the big problems with using bone from my perspective are that, first of all, you can't see under here when you do the second look. So you have to remove this in order to see underneath it. And also when we're doing surgery endoscopically, we don't have a donor site for bone. So cartilage makes a much better solid material to reinforce the scutum defect. And this idea has been around for a long time, as you see from this old illustration. This diagram actually makes it look pretty easy, and a little piece of, like Manuela's actually, a little piece of cartilage covering the defect. But for me, the complexity of this is because not only is the ear canal curved in this direction, so we have to make our flat piece of cartilage curve this way, it's also curved in this direction. So when we remove a bit of the scutum, we have to have the cartilage curving that way too. And if you look at it diagrammatically, we start with a flattish piece of cartilage. We have to make it curve one way, but we also have to make it curve the other way as well. And it's not even as simple as this, because the defect is slightly twisted. So this part may be a little bit deeper inside than this part. So I think it can be difficult to get the cartilage just the right shape, but we do have some tricks to help us. When I harvest tragal cartilage, I normally take the perichondrium on both sides and also take the superior edge of the tragus so that the perichondrium wraps around it. And we could, we can peel that off, the slightly convex anterior surface, and trim off the excess so that we end up with a little cuff of cartilage like this to stabilize the graft. So if we would put the graft in like this, all this perichondrium would get in our way and we wouldn't really be able to see so easily. So if we just trim it and leave a little cuff of perichondrium, that provides some stability of the graft, I think, and it doesn't get in the way too much. And the excess piece of perichondrium there, we can save it to repair some other area of the ear. The other thing that we can do to help get the cartilage a better shape is to help it curve by scoring it. So if you make even thickness cuts, partial thickness, as you see, it allows the cartilage to curve a little bit. And there's another way we can make it curve as well. If you shave it, take off a little wedge from one end, that allows the cartilage to curve round as well. And these are examples of tragal reconstructions of the scutum that I think are reasonably satisfactory. I made an effort in all of them to get the cartilage onto the anterior canal wall, because as you'll see in a moment, sometimes we get a defect opening up here if we don't get the cartilage to fit round here. I note you saw Manuela's technique when there was a little gap here to put an extra piece of cartilage in to help. So making sure that the full defect is covered is important. But while these look reasonably good, this one here has a little recess on the lateral aspect where in a bad ear, I think cholesteatoma could grow in. This one has a prominence of the cartilage anteriorly. So there's a gap, a recess in between here and the eardrum into which troublesome disease could grow. And this one has a bit of a gap between the tragal reconstruction and the pars tensor reconstruction, again, into which in a troublesome ear, cholesteatoma would grow. So how can we do better and make these reconstructions more perfect is the question. And these show some of the examples of failures. So perhaps the most common area of failure that I've seen has been anteriorly. Now, in this case, there was a big scutum defect and the cartilage wasn't big enough to cover this area anteriorly. But in this case, and also this one, I'm sure that I did not put the cartilage in that position, that I put it onto the anterior wall, but it slipped, it's migrated posteriorly, and a gap has opened up. It's interesting, I've never seen recurrent cholesteatoma behind this graft. I always see it in front of the graft, which makes me wonder if maybe epithelial migration is putting some sort of traction force on the graft and pulling it back. Or maybe, I don't know really, why does it always move posteriorly and never anteriorly? Perhaps it's just the geometry of the ear, or who knows, but this is the commonly a problem area. But can happen in other places too. As I said, this is lateral to the cartilage graft. The cholesteatoma grew in between the scutum graft and the canal wall. Looks like this one might do the same thing in through here. And here's one where the cholesteatoma is growing in inferior to the graft. I guess you could say this is anterior as well. but there's a gap between the cartilage and the malleus. Here again, there's a gap between the cartilage and the malleus where recurrent disease grew in. Now, so those are the kind of problems that we can have with getting a good enough fit of our reconstruction. I think that some of you may be wondering, well, maybe the problem isn't the cartilage, maybe it's the ventilation of the ear that's the issue. And I think that in many cases that may be true. The thought is that if a complete mucosal fold grows across here and forms an epitympanic diaphragm, there's no ventilation between the eustachian tube and the attic and mastoid, so gas consumption in this area generates negative pressure, which sucks in this retraction pocket here. This one actually had grown in just behind here, so it wasn't a big cholesteatoma, but recurrence was starting at the first, by the time I did the second stage of surgery. So, and interestingly, when I lifted up the flap in this case, there was indeed a partition blocking the isthmus here. I think probably this edge was attached to the cartilage graft. And so it looks like there was no ventilation of the attic through the tympanic isthmus. However, the tensor fold was actually open. This had been an intact fold at the initial surgery, which I opened at the initial surgery. And in this particular case, it remained open. So there was ventilation of the attic in this case. And so that disventilation theory doesn't explain in this particular case what happened. What I did was to take a piece of cartilage from the Simba concha and put it underneath the original graft. So this is the old tragus graft here. Here's a little piece of cymbal cartilage tucked into the gap underneath the cartilage here. And when I put this graft back, you can see there was a bit of a gap at the lateral edge. And so being pessimistic, I was concerned that recurrence would grow in through here. So I put an extra little piece of cartilage just to cover that defect as well. This is the outcome 5 years later, and it's very interesting, I think, because this is where the second piece of cartilage went. Well, it appears it didn't survive because there's no cartilage underneath here, and yet 5 years after the second surgery, there's no retraction here at all, even though we'd seen some retraction within about 1 year after the first surgery. There was no retraction 5 years after the second surgery. And this is the other piece of cartilage I put in. It's slipped, so now the old tragal graft is underneath the new cymbal graft. Probably this piece of cartilage is doing nothing. This piece of cartilage did nothing. And the ear hasn't recurred. Maybe one day, we're only at 5 years, maybe another 5 years, there'll be a recurrence in through here or in through here or in through here. But from my perspective, if you get no recurrence by 5 years, that's a fairly satisfactory outcome, really. So I'm kind of left with this question is, does cartilage really prevent recurrence? Can we actually do a perfect reconstruction and avoid having little problems like this? And if we can do a perfect reconstruction, how do we do it? So this is where I would like to bring in the panelists for the benefit of their experience. I have roughly 10 questions, and Arun, you can tell me if we're running out of time, but we've got roughly 40 minutes or so. So a few minutes on each question, and we'll see where we get to. And I have to let the delegates know that the panelists, I think I sent you an email with a sort of rough idea of the questions I was going to ask, but they haven't actually seen these questions. I sort of wondered about sending them out before, but I thought it might be fresher to have the first impressions. So I wonder if any of you have tips on how to, particularly, I think, so tips on how to get the perfect graft. How do we get the right size piece of cartilage, and how do we get the right shape piece of cartilage? Some people have told me that they use a paper template to put it into the ear first and trim the piece of paper to fit. Me personally, I never really find that very helpful, actually. I find it quite difficult to do, and the paper kind of falls apart, and it never really seems to translate to the size of the piece of cartilage. So what, Brandon, I can see your videos on, and maybe if you don't mind, I'll start with you. Do you
Sure.
have any tips on how to get the right size and shape piece of cartilage?
Yeah, can you hear me okay?
Perfectly.
Great. So I usually use a round knife, and I measure the anterior posterior dimension of the defect and then the superior inferior portion of the defect. And it's usually done after I've placed my cartilage graft, the portion of my cartilage graft that's going to reconstruct the TM. And so that kind of gives me a rough idea of how big of a cartilage piece I need to create and sculpt. And I've sometimes used the speculum as a template. I use the speculum as a template to make my drum. I usually use an 8 for that. And then for the scutum, depending on the size of the defect, you can use it looks like a half circle or a semicircular defect. So I'll use an appropriate size speculum, based on my round knife width measurements, and use that to make my scutum graft. Other thing I noticed is, you preserve the malleus in a lot of your cases, maybe take out the head and you leave the handle. But I always just find it, once I've taken out the incus, I know that the malleus can provide some advantage for hearing reconstruction, but I just find it a lot easier to place my tympanic membrane graft and my scutum graft when there's no malleus at all, other than maybe like a little piece of umbone. So having the malleus in the way, I think, makes it, both tympanic membrane and scutum reconstruction much more difficult. And so I typically remove most, if not all, the malleus, and I think that helps me with getting the graft in. I guess one could say that there is an advantage to leaving the malleus not only for hearing reconstruction, but sometimes it can actually hold up the inferior portion of your scutum graft so it doesn't fall in. So again, I use the round knife to kind of estimate the width and height of the defect, and then I can use a speculum to kind of create the half circle that would fit in the defect. And again, it's not always a perfect half circle. It can be somewhat ovoid. And then I learned from a conversation with you. I was sitting with you and Matthew Young, and I don't remember when or where that was, but we were talking about scutum reconstruction, and I really took it to heart that he basically tries to wedge this graft in there. You have the graft slightly bigger than the defect and try to wedge it in the defect so it doesn't fall in. And I try to do that, and I aspire to do that, but it isn't easy doing it. So I don't usually score the cartilage. I used to have a little perichondrium covering the whole thing and have the edges lay over the bony canal. The problem with that is that sometimes it made it hard to see the cartilage and where exactly it lined up with the edge of the scutum defect. So now I just use cartilage with no perichondrium on it so I can see exactly where it's going, and then I cover it with extra perichondrium after it's been placed.
Those are superb tips, actually. Thank you, Brandon. I've always liked the idea of, I've always kept the malleus in place because I felt it provided some stability to the normal position of the tympanic membrane, but it does get in the way. I agree with you. So that's a really interesting thought. I'd always liked the idea of keeping the perichondrium on as a way of trying to keep the cartilage more viable. But I agree with you entirely. It does get in the way. It can be very hard to see that the cartilage is in the right place when there's a little flappy bit of perichondrium around. And I'm assuming that you've not had any trouble with viability of the graft when I guess you're covering it with a piece of perichondrium afterwards, so maybe that helps to keep it alive.
Yeah, I definitely don't have perfect results. I mean, I will have some of the things that you've shown and post-operative results. Any little gap, they can definitely recur. And then I've had ones that there's like a huge space that's not covered with cartilage that looks perfectly ventilated. And I'm like, well, I just got lucky that was a behaving ear. So, yeah, I mean, I think we all have the same struggles with this technique. If I've had to do a combined approach where I open up the mastoid, and then have to do the scutum reconstruction after that's completed, I do a lot of obliteration now. So I'll collect bone pate in the mastoid, and then I will basically fill the entire epitympanum and antrum with bone pate, and then put the cartilage on top of that. And then I try to use a piece of cartilage to separate the middle ear from the epitympanum, medial to the scutum graft that kind of sits just lateral to the tympanic facial nerve. And so I've done a lot more obliteration lately to hopefully prevent this recurrence problem. And in some cases that may be overkill, because obviously you show the cases where your graft is not really covering your defect and they do fine. And I've been using obliteration maybe for a couple of years now, and I haven't looked at my results, but I feel certainly better than when there's that whole space is obliterated essentially, so there's really no place for them to recur. But the downsides of obliteration is you really have to be comfortable that you've not left any residual disease behind, and we all obviously rarely leave a case where we feel that way, but obviously residual disease can be there, so that's an issue.
No, thank you. So if we've got time, I'll come on to the obliteration question later. I wonder if Muaz or Brandon's given us some very good tips. I wonder if Muaz or Nirmal, you have any additional points you'd add to that. Also, there is the extra question whether the tragus is the best piece of cartilage to be using for the scutum, or whether we should use the Simba concha. Nirmal, maybe first, and then Muaz.
Yeah. Thank you for inviting me along, Adrian, and hi to everyone. A few things to say. I think the first thing for our audience is preparing it. I think the tragus is probably the ideal initial graft to choose from. I know Adrian's published on this actually about 10 years ago or 11 years ago. He was comparing his symbol, tragal, and autologous bone results. And you demonstrated, I think, Adrian, that the tragus in your groups was better for hearing and stability. But I think it naturally has the appropriate concave shape, or the three-dimensional geometrical shape that we're looking for, probably. It tends to be more even with its consistency of dissection. I think an initial point to make for the audience is preparing the tragus area is very important. So injecting with whatever local and adrenaline that you like to use, so that you have a nice dry field and you can dissect all the way medially to the medial aspect and superior and inferior to get as much of the tragus as you can, so that you've got the best possibility of reconstructing a large AP dimension, is an important point. I, like Brandon, tend to size with the round knife or with the short, medium, or long Thomason. So I sometimes use that to estimate the size. We had a lovely session on aortic reconstruction at our course just a couple of weeks ago in Sydney, and I'll share a couple of things that Dennis Poe mentioned to us that I thought were very good. And also Alex had a very nice trick for sizing, which was to use the foil of a suture, the foil of the suture packet, and then use an angled hook and then create a puncture around the edge of where the defect is. And then you can cut that out, and that might simulate the size of the grafting that you might want to do. And the other point that I've tried a couple of times since Dennis came is he mentioned a technique that John Dornhofer has described, where he uses a 1 or a 1.5 millimeter straight diamond and turns the previously curved edges into more vertical ones anteriorly and posteriorly. And that enables you potentially to lock in the graft a lot better. And as you mentioned, the locking's an important point in trying to, in other words, you sort of oversize the graft and overcut the graft to allow it to lock into place. So I've done that actually a couple of times afterwards and found that quite useful. I actually shape the graft just with a round knife, usually just cutting vertically down onto the perichondrium, leaving the perichondrium as it is, and have a tight fit. And then like Brandon, I tend to do the tympanic reconstruction first, and then try and identify the size of the scutal defect and then lock that into position, like you mentioned. And I actually have taught our residents ever since Brandon came to our Sydney course, the Isaacson technique. So I actually lock it into place and then irrigate profusely with a lot of saline, which is a technique Brandon taught me for OCRs. and I do the same thing to ensure that it's locked into place and it doesn't move. And I think that's another little nice tip. And lastly, I think it's important to mention to the audience, there is quite a big difference between pediatric and adult, because in the pediatric population that I think you're mainly dealing with, Adrian, you have a difficult group. I mean, they clearly have a much higher residual and a higher recurrence rate than the adult population. And also the tragus, particularly in the younger children, may be more elastic and thinner and not as big. So you're dealing with a lot of challenges that you don't necessarily get in the adult population.
No, thank you.
A few comments there.
They're great, actually. And some of these comments we'll have the opportunity to talk about again in a minute. They're very insightful. Thank you. Muaz, do you have any sort of general comments about sizing and shaping the cartilage to get it to fit?
Well, I always almost consistently face a deficit of cartilage. So my first advice is, go slow when you do your episiotomy, and really feel free to go back and go from the other side to get to the disease cartilage, rather than creating a huge episiotomy that you have to reconstruct later on. The second, so of course I take as much cartilage as I can from the tragus area. And again, in kids specifically, a lot of time you get a deficit. And I've really sort of kept away from this idea that I don't have one piece of cartilage that I'm gonna model it perfectly. I'm just gonna fit the defect extremely well. So I don't have trouble, dividing the cartilage in small pieces, but of course I use a lot of soft tissue overlying the cartilage. So when I take my pericardium, I try to get really very thick, get some of the muscle. So I mean, we should not think either pericardium, thin pericardium versus cartilage. I think there's some in between there. If you have a lot of tissue, it would also support your reconstruction. And the last point that I want to make is that I think the pathology makes a difference. So for me, if you have a Prusak space cholesteatoma, I think we need to distinguish between a true attic cholesteatoma or a Prusak space cholesteatoma. Prusak space cholesteatoma, I think you could do a soft reconstruction and you're not going to have a problem. When you get the true attic cholesteatoma, that thing will sink in no matter how. I mean, of course, you want to do the best job that you can supporting it, and I agree with the concept of obliteration of the attic with some bone dust or some even longer.
Yes. Okay. Thank you. So you made the comment about deficit of cartilage, not having enough, and that's certainly sometimes that we sometimes see in children. I find it very frustrating. I'm sure we all do when there are big fissures of Santorini like this that bisect the graft and stop you getting enough. So what do you guys do when the tragus is too small? I think Muaz said you might go to the other side. I've asked this question in panels before, and some people have said, oh, slice the cartilage to make it thinner so you get twice as much. But I often find, at least in kids, that isn't really robust enough. So I've started using the Simba concha. So that's to answer my own question, but I wonder if you guys have other suggestions.
I usually just go to concha if the tragus is too small, but I agree. You'll sometimes see these fissures of Santorini, and then then you end up just with like this macerated piece of cartilage that's really hard to use. So I think we've all been in that scenario, and I might go to is concha, but concha is definitely harder to work with. It's much harder to peel the perichondrium completely off one or both sides. It has a innate curvature to it, which for scutum reconstruction is probably pretty nice, but for TM reconstruction, it's not so nice, I feel. So, but that's what you got. I've rarely gone to the other ear to get tragus. I've maybe done that maybe once or twice in I don't know how many years. So I prefer to leave that in case the other ear needs it. So. Yeah,
me too. The and you said concha, the conchal bowl, or the Simba concha, the just above it?
I think the Simba's nice, a little nicer because it's flatter, and I think it's a little easier to dissect out. So that would be my preference if hopefully it's big enough. Usually it is.
Yeah, and if it's a more even thickness too, isn't it?
Yeah.
The conchoid
Yeah.
bowl is kind of a bit irregular. Any other thoughts, Nirmal?
I do like the concha, and I sort of make an incision just under medial to the antihelix all the way around, and then fold the flap so that it's based anteriorly, the skin flap, and it gives me a large amount of cartilage to work with. It is trickier to dissect with, as you mentioned, Brandon. Sometimes it's actually relatively thick and can, in a small volume attic, really sit nicely and block off the attic really well. So sometimes it's advantageous compared to the tragus. But yeah, if I had this situation of large fishes, I'd go to the conchal bowl first, not the Simba.
Thank you. So both of you, well, you all mentioned the, about stabilizing the graft, about trying to lock it in place, and I remember that conversation. I've had it a couple of times actually, Brandon, with Matthew Young about locking it, and I must say when I tried it, just springs back out again. I haven't really got it to work, so I'm going to have to see how you do it. But these are pictures from Mirko Toss's beautiful book that was published years ago, with techniques that he espoused for locking the graft in place. One was to peel the perichondrium off both sides and leave it attached at the edge, and then fold the perichondrium back against the bone. He also proposed drilling a little notch in the bone to accommodate the edge of the cartilage, and then this even more elaborate thing where you slightly bisect the edge of the cartilage so that one bit locks in and then the other comes out onto the surface. He obviously, I mean, he's well known for having this beautiful, very skillful medical illustrator for these books. There's a wonderful collection of illustrations. Although I would find it hard to draw this, I think I would find it harder to do it surgically. Have you tried any of these kind of techniques, or how do you get the cartilage to stabilize?
As I already explained, I really don't. I think this idea of locking the cartilage in place and just fitting it just right, it has really never worked in my head, and I think I'm too impatient a surgeon to take that out. So basically, I do divide the cartilage sometimes into multiple pieces, but I make sure that I cover everything with a very, very thick soft tissue.
Yeah. Okay, thank you. Yeah. And Brandon, how do you get it to lock? You just shove it in the hole and it stays there?
Not always. So I mean, I try my best to get it to lock in place, and so sometimes you'll still have little gaps. So I'll take the pieces of cartilage that I trimmed off it and fill it in the gaps. So it doesn't always work out the way you had it planned out in your head. But
yeah,
in that case, I fill in the gaps with small pieces of cartilage. So.
Yeah, definitely. You save every little piece, don't you? And it's remarkable how those little offcuts are sometimes the perfect shape just to go in that gap, aren't they? So to kind of wrap up these sort of discussions of the technicalities of getting the perfect graft, when it won't fit, and you've done all these things as best you can, what do you do? Do you ever find that using a microscope helps, or using two hands to stabilize the graft? Is that why we're having a problem, because we're trying to do it with one hand? Or Nirmal, maybe you can start, because I think you said you sometimes reshape the bony defect to get the cartilage to sit better. I agree with you. I think that can be really helpful. Sometimes I just use the curette just to lower the posterior aspect of the scutum to try and make it a more even recipient for the graft. But what's your what do you do when the cartilage just won't behave?
Yeah, definitely two hands is very useful for me with the microscope. It's still transcanal with the speculum. And I find sometimes two hands is quite useful in applying pressure in one area and simultaneously pressure posteriorly to try and lock things in. And then as you mentioned, I try and reshape, not too much, but just a little bit to see if I usually will oversize the cartilage, and if I've oversized it, I slightly make the bony defect a little bit bigger to lock in the cartilage.
Muaz, do you ever bring in the microscope, especially just for to position a graft, or what are your thoughts about that?
I never had that experience that I never found the microscope to be a better instrument for that than the endoscope. Of course, when I prepare the graft, I prepare it with the microscope. But
yeah, the problem that I have, I must say, I like your point, Nirmal, that if you've got two hands, you can apply pressure to stabilize it better. The problem is, when I bring in the microscope, I can't see anything. So it's that perpetual dilemma, isn't it? The good view with the endoscope or the two hands with the microscope. And what would you do, Brandon, when the cartilage just won't fit?
I've sometimes, if I have a lot of extra cartilage, I will stack it on the medial wall of the epitympanum and put the main piece on top of that. So I've done that, but you know, again, the concern about that is if you have a recurrence or residual, going back in there is going to be a real pain. But I've done that before. Again, I've sometimes shaved down made the defect a more, if there's any irregularities in it, using a curette or a drill to kind of shave it off, like you've already mentioned. But those are the things that I would use. And again, little pieces of cartilage to fill in gaps. So nothing, not too much more to add. I have not used the microscope to do the scutum reconstruction, but I can certainly see how that would be useful.
Okay, thank you. So that concept of using the some sort of support in the attic to stabilize the graft is a good one. And Brandon, was it you? Brandon, you mentioned that you're increasingly using obliteration of the attic to stabilize, for a better reconstruction. And of course, the problem that most of us have is that if we've done a totally endoscopic ear surgery, how do we get enough bone? We can't really get enough bone to do that. And so Stefan Ayash has published this nice technique in laryngoscope of using bioglass to obliterate the attic. And then he puts thin pieces of cartilage over this to end up with a beautiful looking result like this one. This is just one case that he's published. And unfortunately, in North America, we don't have access to this material yet, although the company is working on getting FDA approval and hopefully eventually Health Canada approval. So it may be coming to us. But Nirmal, Muaz, your thoughts on this? There's kind of a bit of a paradox here, where some people are saying we should be opening ventilation pathways to get better ventilation. Other people are saying we should be actually filling in the space and blocking ventilation. So what are your thoughts?
I personally think I don't think anyone knows the answer. I think it's difficult, and I think that's why classifying and international collaborative outcome research is so important, because I think a lot of this depends on the type of the phenotype of cholesteatoma that you're dealing with, and the ventilation pathways that already exist in the temporal bone, the size of the mastoid. I mean, it is slightly counterintuitive if that was a very pneumatized mastoid just to block off the epitympanum. But then again, if it's a very small mastoid and that you're seeing the limits of the antrum, then this technique is ideal. I think it's important when you're using these bone substitutes to cover them probably with cartilage. All of the evidence and the data seems to suggest that if you do obstruct the epitympanum like this, I think, as Stephanie describes, to cover it with cartilage and maybe even separate the mesotympanum from the attic with cartilage may be important. But like Brandon, and as Muaz intimated, I think if there's a lot of disease extending posteriorly, instead of doing an inside-out mastoidectomy sort of endoscopically, I'm doing more and more just post-auriculars and trying to preserve a lot of the attic and then obliterate. And I'm not sure if that's the right thing either. Having read for this panel, I mean, even in long-term studies of bone pate obliteration from post-auricular, like 25 to 30% of the time, the bone disappears in larger series after 5 years or so. So I'm not quite sure what the right thing to do is. But I'm tending to certainly obliterate more with bone pate, and exactly as Brandon mentioned, try and create a sort of pyramid of cartilage that locks into that suprageniculate area in front of the lateral canal, above the in front, sort of superior to the tympanic facial nerve and along the middle fossa floor, and then just pack everything behind that. Much like they've been doing in many of the European countries for nearly 2 decades now.
Mm. Thank you, Namal. Yeah, I agree with a lot of what you said. Moaz.
Yeah, I really think that, you know, of course, when we started talking about endoscopic ear surgery, we had every incentive to drum up the ventilation issue. But I really think that, I mean, my experience is that somehow in a lot of my patients, this issue of ventilation, whether I did something to maintain it or to, it just doesn't work. Clinically, as he had mentioned, you have a good ear and you have a bad ear, and you can't tell why this ended up this way and this ended up that way. So I really don't spend now too much time thinking, oh, well, I'm going to have to maintain ventilation and stuff. I don't think it makes a big difference. I think the best thing to do in this kind of situation where you have such a significant defect is to have something hard and stable supporting your reconstruction. And I think the idea of, again, obliteration is something that we need to consider.
Yeah, okay, thank you. So one of you kindly gave me the excuse that maybe kids are more difficult than adults, and indeed we do have quite good data showing that recurrence rates are higher in children. These data are taken, or the graph is taken from data in an international otology outcome group study of 1,400 patients, actually, so pretty clear higher recurrence rate in the kids than the adults. So I wonder if that is because scutumplasty is easier in adults, maybe because the cartilage is different or the ear canal is bigger. Does that make it more effective, or is it just different pathophysiology in adults, and maybe adults don't actually need cartilage at all because they're not going to recur anyway? So do you think that this is making a difference, that the cartilage reconstructions are better in adults, or maybe the adult surgeons are better and getting better results, or is it just different pathophysiology? I mean, I think, no, well, actually, as you said before, we don't necessarily know the answer to this question. That's probably the correct response from an evidence-based perspective. But what's the opinion from you guys?
Probably the adult surgeons are better.
Well, you guys do both, so how does that work?
No, I mean, I think it must be obviously many factors. The most obvious one would be pathophysiological, eustachian tube dysfunction, inflammatory mediators in the middle ear. There's a lot of evidence behind that stabilizing beyond the age of 18 to 20. And as I mentioned, I think the tragus is just probably not as robust. It's more elastic, more difficult to lock into place. It's not as thick. I think they're probably the main things in my mind. I think that, and of course, the canal is, as you mentioned, wider, so it's relatively easier in a lot of adults. But then again, children canals are relatively shorter, so sometimes you can just get in there a little bit easier.
Mm-hmm.
I think basically when you have, again, somebody who's 40 years old, took them 40 years old to get to that significant disease, and you have somebody like 5 years old and it took them like 5 years to get into that amount of disease. I think you need those a different situation here.
Mm-hmm. Yeah, no, I think that's, I agree. Yeah, yeah.
Does this? Oh, go ahead. Sorry.
Can I say something?
Yeah.
I do both adults and children, and so like Nirmal said, I don't know whether I become suddenly a bad surgeon doing children, but I always note that the children's reconstruction is much more difficult and they're more likely to recur. I don't know. I think, in my opinion, if they have developed the disease at that young age, it just obviously means that they got bad eustachian tubal function or some slightly different pathophysiological mechanisms, which is making them bad, because when you do both, this is the conclusion that I'm getting. And you know that my data is also in that paper that you just mentioned. So
yeah,
it's one of those things.
Yeah.
Did the paper exclude kids or children with syndromic or with craniofacial syndromes like Down syndrome?
No, although they're so that's a fair point, but they are a relatively small proportion of the total. But yeah, it's a fair point. There are some syndromes. Turner syndrome and Sotos syndrome actually are two that get some of the worst results. But you're right, Brandon. That contributes. But I guess those adults have those syndromes too, don't they? So yeah. So I have one other key question, and Muaz, this is especially for you because I've asked your opinion about this over the years, so the question that I'm asking now is: does a larger defect of the scutum increase the risk of recurrent disease? I think this is a very important question because it basically determines when do we convert from a totally endoscopic case to a canal wall up tympanomastoidectomy? How far do we chase the disease posteriorly before we convert? How big an atecotomy do we make before we convert? And so if doing a small atecotomy and a mastoidectomy has less risk of recurrence because we can reconstruct it better, then we should be converting earlier and just doing a small mastoidectomy. And so to try and answer this question, I've been monitoring my results of large atocoantrostomies, totally endoscopic surgery, for cholesteatomas that are in the mastoid antrum, but don't go much further into the mastoid than that. So, and the historical control I have are cases that I did in the old days with a microscope, where and so that basically the two groups are roughly matched in terms of the size of the cholesteatoma. They all went into the mastoid antrum, but didn't go into the mastoid air cells any further than that. And I've been speaking to Muaz about this for years, because when I started doing this analysis, my early outcomes for the endoscopic group were terrible. They were significantly worse than the canal wall up group. And so that made me conclude that a big atecotomy is worse. It's harder to reconstruct. There's more risk of recurrence. And so I stopped doing that and started doing converting earlier, doing smaller atecotomies and canal wall up. But you can see as time has gone on, now these two groups are indistinguishable. The recurrence rate seems to be the same, whether I do a massive atecotomy or a tiny atecotomy. You have to note, though, that the numbers are small. There are only 23 in the endoscopic group, and there are only 2 of them that have made it out to 5 years. And so that's why the confidence intervals for the endoscopic group are so massive. Okay, so this isn't really publication quality data, but I don't think we have any better data than this, really, unless that I'm aware of, to answer the question. And so I've started doing these smaller atecotomies again because of my early concern, and I've had problems with that too. So damn it. This is a case where this is at the second look after a small atecotomy. It's healed so well you can't even see where the cartilage is. I guess it's still early days and the skin's still a bit thick here. But when I lifted up the cartilage graft, there was residual disease behind this small atecotomy. And I think that by doing a smaller atecotomy as part of my canal wall up surgery, I didn't get such a good view behind the scutum here, and I left residual disease. And so, sure, it was easy to do a good reconstruction, but then I had residual disease. And so I think this discussion is a bit more nuanced than I first thought it was. But I know, Muaz, I really value your perspective because of your long experience, and I'm interested to hear what you think about the, well, let's say the hazards of doing a large atecotomy, and also, the hazards of doing a small atecotomy.
Well, I don't have any statistics to support my argument, but I could tell you one thing for sure. I made a U-turn. And usually in life and in surgery, when you make a U-turn, you know, surgeons don't like to make U-turns. They like to go all in the same direction. And it takes really a lot of sort of bumps in the road and accidents before you make a U-turn. So I made a clear U-turn. I try very, very hard to limit my episiotomy. I don't see what you're seeing with this slide. I don't think that I'm leaving residual disease. I think the opportunity to go, you know, if you do open up the mastoid and the attic very well, and you use endoscopes to go through the mastoid and the attic and remove disease, I think you could get to the disease from the other side of the scope. But again, this is one area that my practice nowadays for the last maybe 5 to 10 years have been very, very different from the early years of my practice with endoscopic ear surgery.
Well, that's really helpful and good. You know what, Miraz, it's always so helpful to hear surgeons give that kind of to reveal the fact that they have changed direction. Sometimes people kind of cover up those changes in direction, so it's really important for us to hear that. It makes me think of Gordon Smith from Belfast, as in the days of the Canal Wall Up, Canal Wall Down debates. I think he came to similar realizations. I know, Arun, we've got 4 minutes left or something.
Yes,
yeah.
yes. So I just wanted to mention that.
Yeah, no, we're perfectly in control, actually. Thank you to the panelists, because your answers have filled the allotted time perfectly, and we've only got one slide left after this, so which is a summing up one. So, Nirmal, what do you think? Big attocotomy is okay, and better, or small attocotomy is better?
I think it's really important to differentiate the type of disease that you're dealing with. And so we do tend to stick to that 10-minute rule in Sydney, where if we're getting a nice clean dissection around a capsule, which is easily dissectable after the standard attocotomy, which I would define as a maximum of an average round knife, 3 millimeters, 3 millimeters from medial to lateral. And if we're clearly dissecting around that, then we'll keep going and not perform a mastoidectomy and try and remove it that way, particularly if it's coming out as like Manuela's with a nice capsule around it. But if it's 10 minutes and you're digging around, we just switch to the mastoid. And I agree with Muaz's comments that I think you can get a complete view from behind. And as Brandon mentioned, and as I've already mentioned, I tend to be doing a little bit more mastoidectomy and obliteration now with cartilage block.
Okay, and Brandon, your thoughts?
Yeah, I remember talking to Stefan about this, and I've tried to, if I'm kind of futzing around in there trying to get disease out and it's not coming out cleanly, I think it's just easier to go post-auricular and not create a huge defect. But again, I like you said, I don't think the data is out there to support one over the other.
Okay, which is a pretty good segue to the next session on how to collect good data so we can answer these questions better. Nirmal, you set us up well for that too. So now this is the final question, okay? And because we've got like 90 seconds left, you're only allowed a one-word answer to each question. So what's the chance of a perfect reconstruction, and does it prevent recurrence? I guess it's like multiple choice. You can have always, sometimes, never. Okay. I'll maybe allow you to embellish your answer a little bit more, but just concisely, what do you think?
If you're lucky.
Muaz, you far away, yeah.
If you're lucky, you'll get.
Yes, okay. Nirmal?
I'd say 30% and 30%.
Okay. And Brandon?
Probably similar numbers to Nirmal.
Yeah, okay. Well, thank you all very much for your very insightful answers. It did look like Diana was actually making notes, and I just saw your on the video earlier. I don't know if you still are or if you were, but it did occur to me that these answers would make a great chapter or opinion piece somewhere. So if somebody wants to pull it together, I think that would be good for all of us. Thank you very much. Very insightful.
Two questions,
Oh, are there?
in
Oh,
the session. Okay, so one of them is that any experience with synthetic cartilage matrix? That's one of the questions. Have you used anybody? No?
No.
Okay.
no,
So
it's a
the
great
question
idea.
is, yes, so that is, so that's a simple question to answer. The other question is, one of the surgeon is asking, as a junior ENT surgeon starting my otology service, I was exposed to conflicting opinions regarding scutum plasty between don't reconstruct for better surveillance versus always reconstruct. How do you choose which cases to reconstruct and which not to?
I think I mean, if there's a scutum defect, I typically always try to put a piece of cartilage in there. And then, again, the ones that have, then we can use second look. And when I've done second looks on these patients, and I don't know my percentage of patients that I do second looks on, but hence I need to be contributing more to the database. The cartilage usually lifts out the scutum defect pretty easily. Again, which goes back to, is the cartilage really doing anything? And again, I still don't know if we don't have the answers on that. So I reconstruct every time.
My thought is it depends a bit on your opportunities for different surveillance methods. If you're in a resource-rich area where you can do a second look on everybody really easily and you can do MRI easily on everybody, then there's no problem with covering it with cartilage. It does come back to the question, does cartilage really work? And if anybody really believes there's equipoise here, then maybe we should have a randomized controlled trial to find out whether it really does help, which would be a big multinational, big multi-center effort to get the answer over years. But I think that cartilage might help sometimes, so I would put it in, and then, as Brandon says, do a second look to check.
Excellent, guys. I think it's a very interesting and stimulating session with no easy answers at the end, but that is the nature of the problem anyway. That is why we're discussing this.
Yeah.
Thanks, everybody. So I think we'll move on to the last session. So that last session is about reporting outcomes in cholesteatoma surgery, and it's a very important topic. So I'll just share a screen. I'm going to give a small presentation because that will set the scene. And then can you all see my screen? Okay. So, yeah, okay, great. So there are a lot of advances in various things, and we know that but the data collection seems to be a bit of a difficult thing, because of various reasons. For example, we got artificial intelligence. This picture on the left is about difficulty and challenges in data collection in ear surgery according to Picasso style. And this is the picture the AI is drawn for me. So you can even do that, but it is very difficult to get people to collect data. So I thought about various reasons why that may be, but then I decided that, okay, I'll do a bit of cheating and cheat GPT. I asked the question to the chat GPT just for fun, okay? It came up with 13 causes, like data standardization, availability, and privacy, and quality of data, etc. So surprisingly, it came broadly to these 4 points which I thought about, and there's the same points given by ChatGPT. So I think that the difficulty in collection of the data, for example, is due down to availability of records and privacy laws and reluctance in participation and standardization of data. I know you're all going to talk about each of those things, so it'll set the scene. Quality of data and completeness is an issue, and nomenclature of surgery and duration of follow-up. How long do you do? And security and bias, for example, would you avoid marking a negative outcome? So these are all stumbling blocks, but sometimes the stumbling blocks will lead a way to reach somewhere. That is the point. So in my opinion, what happens is, my life was completely changed after I started collecting data. And there's difficulty in collecting data because you keep a paper copy somewhere and then, you don't know where it is, and, you move between 3 different sites. It's a difficult problem. So I think prospective data collection is the best, and it should be anonymous or safe in a hospital, but electronic databases are better. And reluctance in participation is the other issue that I see. Again, I think each surgeon, they collect the data, but they're not very happy to share it. And there is also some of my colleagues say there's no time to do the data, and they don't have enough help. For example, they expect the artificial intelligence to automatically input the data, which is not going to happen, at least in the near future, as I can see. I stay back after hours, after operating, after a long day. I do not go home until I finish the data. And the other thing is that if you're sharing data, the surgeon should be anonymous, otherwise there will be reluctance. You can see this difficulty in collecting data according to Da Vinci style. The other thing is the standardization of data, okay? You can see it can be summarized in the 4 blind men describing an elephant, according to Salvatore Dali style. Again, you don't know what you're collecting, and all the necessary details are not there. Audiological data, for example, it can be missing, or some frequencies are missing. According to the American Academy classification, you need to have 3K. There are ways around it, but my hospital doesn't always include 3K. It's a problem, but I try to address that. Missing data can be an issue, and but the bigger problem is the nomenclature and variability of the surgery, the pathology, and the ossicular chain reconstruction itself. That is the main problem. So what is, according to you, is a canal wall down may not be what is canal wall down for Adrian. Adrian is telling me that even if you remove 1 or 2 millimeters of scutum, it becomes a canal wall down operation, according to some people.
Yeah, not according to me, according to somebody
according
else.
To some people.
Yeah.
That's what I made it clear.
Yeah, absolutely.
So again, the security bias, okay? Where do you keep the data and who is going to monitor them? And it's a very difficult problem because I was always using Matthew Young's database, and it is locally secured and it is kept in the UK. But there are other people all around the world using the database. And how do you avoid leaks and protect patient information? The problem in the UK and in Europe is that the data protection is so difficult, and if there is a leak of anything silly, then you may be sacked or you might even be suspended for that. So it becomes a big problem. And then there is bias, the selection bias and outcome bias. Selection bias can be avoided if you include anything that you do, so that there's prospective data. That's what I do. Outcome bias, again, I mention everything in my outcomes so that I know myself what's going on. So the need for a uniform data set that is being discussed in the future, in the next talk. So I'm going to not sort of dwell on it. So my own personal experience is that I started the audit after, I got the consultant job in 2007, and then I collected data on a paper and, mainly about stapes and laryngoplasty, but then a chance meeting with my mentor, Janet Wilson, led me to go and speak to Ian Swan and Matthew Young eventually. They just decimated my idea that, they asked me how good you are and, how good are you and how do you know? And you don't is the answer unless you do a prospective database, keep it for minimum 5 years, minimum, and then your outcomes are sort of, comparable. So I started the database in 2009. I've never looked back. I enjoyed it. It was labor intensive, but then what happened is Matthew Young retired, and, in spite of his best efforts, he just couldn't get anybody to continue. But I'm not saying that this is there was no challenges along the way. Endoscopic ear surgery, I started doing endoscopic ear surgery 10 years ago in 2013. Then again, we have to change the database. I approached Matthew and he was happy to include that, and that was good. Then we came with SAMI auto classification and the GDPR. That is the main thing that threw a lot of spanner in the works. There are 7 things that is we needed. You need permission from the patients, confidentiality, accountability, and the length of storage and everything. So, but extremely fruitful is the audit, if you can do it, personal audit. So I think, in my opinion, the future of ear surgery audit is bright, but being the devil's advocate, as you can see, I think, we all should be doing it, and, the negative outcomes should be discussed, and the major complications we should be able to see. Otherwise, we won't be able to get anywhere. So any future audit, if possible, it should be accessible across the globe, it should be free, the data should be uniform and GDPR and locally compliant, and the data sharing can be made easy by making it anonymous, and each surgeon is responsible for their own data. But sometimes it feels that it's a superhuman effort, after a long day of operating, you're sitting there, and so, but it's worth it. So that is why I was very happy when Adrian came up with this REDCap database. I know that he's going to talk about it, so I won't dwell on it, but I had also a lot of problems in setting it up. In my hospital, just wouldn't do it, because they say they don't have no interest in setting it up in my own hospital. 1 or 2 surgeons are using it, so what? It's taking up a lot of data, and they're not interested. Luckily, the Glasgow University have got database. So what I came up with is a totally anonymous REDCap database based in Glasgow University, and I have a key, a REDCap's key for audit, where I put numbers for each of the patients and hospital number, and that is kept in my own hospital's computer, so that I know which patient is number 56, for example, and then I can monitor that. So that is how I overcame this difficulty, but I'm still not able to convince any of my colleagues to use this. Only small number of people are using it. In fact, they are trying to develop their own database, which I am party to, and they're only looking at myringoplasty for some reason. And I'm not sure how much we are going to achieve, but they think that starting slow or small will help encourage people to sort of input the data. I'm not sure. So in summary, I think the difficulties are with the uniform data collection and use validated nomenclatures for surgery as well as audiology and everything. Include all of your patients. Follow-up is the key. That is the other thing. How do you follow it up? In the current day, I'm working in the NHS, and the NHS is struggling to cope, and they're trying to reduce the number of follow-ups, and unnecessary things are given to the nurse practitioners. So I'm trying my best to see my patients for minimum of 5 years, especially with cholesteatoma. And I might even have to follow Matthew's footsteps and do audit clinics completely free of charge, so that they won't have an issue with that. And please, if anybody, all the listeners, please report your outcomes and complications even anonymously to us. The International Working Group is keen to know if there's any unusual complications, for example. This will be eventually better for all of us, and the patients and the surgeon, I would say. So with that, I think I would stop with this nice picture of a sunset in Largs in Scotland. So I think what is going to happen is we are going to now, Nirmal, I would invite you to speak about the Iano-Jones classification of cholesteatoma.
Oh, thank you. Can you hear me, Arun?
Yes.
Yeah, this, as you mentioned, this very exciting topic, which I think as I share with the participants in this panel, I think it's an extremely important topic. It's really challenging. I think one of the biggest things for us is really time. And as you mentioned, you're staying back late after work and entering them in. And probably the other big one for us, because we've been trying to implement databases through our Australian society, is just the lack of participation. And it's difficult to work out why people are not keen to do this. It's probably time. It could be that they don't want to share bad results, not quite sure. But I think we all learn from sharing the bad results, and that's how we all improve. And this is really a short talk about the history of this European and Japanese Otologic Society classification of middle ear cholesteatoma. This was work that was presented and published in 2007 17. And the idea is really that we should try and develop, as Arun mentioned, an international collaborative outcomes research effort. So we need to standardize definitions and classifications. And this allows for collaborative outcome analysis. And hopefully this will allow us to predict and reduce ultimately recidivistic disease, which for our junior trainees is residual disease is disease that we've left behind in cholesteatoma, and recurrent disease is disease that's occurred after we've reconstructed. So that's the whole purpose, is to try and improve outcomes for our patients. And this can really best be done in the setting of cholesteatoma, I think, with these large collaborative works because of the duration of the outcome analysis that needs to occur. So really the history of this began in Collie 2016 in Edinburgh. I think Adrian was part of the 44 delegates, who was one of the main conveners, along with Matthew and several others, with a subsection. And they wanted to create a logical, a categorical, and an ordinal system that's easy for us otologists to enter data in. And there was debate at the consensus meeting, a debate between trying to get a system that was simple and easy versus one that was more complicated, more data entry required, but could prognosticate better. And there was a 75% agreement on staging. And this ended up being one of the bugbears with this particular system. But there was a very high consensus with this type of division of Middle East spaces called the STAM classification: S for difficult sites, T for tympanic cavity, A for attic, and M for mastoid. So it's quite logical to understand how we get the STAM system. And this was really a staging system that applied to only 4 types of cholesteatoma. So this is from the paper looking at various subtypes of cholesteatoma, and I've highlighted the 4 that this staging system applies to: congenital, the pars tensa and the pars flaccida cholesteatoma, and cholesteatoma of tympanic membrane perforation. It specifically doesn't include anything to do with recidivistic disease or any other subtypes. And the staging system it's fairly simple, actually. When you're looking at pars flaccida or pars tensa cholesteatoma, stage 1 is 1 site, stage 2 is 2 sites, stage 3 is extracranial complications, which are fairly logical, and I'll describe them in the next slide. And then stage 4 is with intracranial complications. And so extracranial in the paper was subdivided, and this created a stage 3. And this was what is really fairly intuitive for most otologists, that there's a facial palsy, labyrinthine fistula with a risk of membranous labyrinth damage, labyrinthitis, canal wall destruction, specifically more than half the length, a tegment defect specifically requiring repair, and then abscess formation, classically postauricular, zygomatic, or into the neck. And stage 4 was anything intracranial, again, fairly intuitive for all of us that are doing ear surgery. So meningitis, epi or subdural abscesses, sinus thrombosis, and interestingly, brain herniation as a stage 4 disease. So this, as Adrian's already mentioned, was then subsequently assessed for validity, and this was published in 2020 with a series of 1,482 cases. And there was just over a 10% staging discrepancy between different raters, but a very high inter and intra-rater reliability. So this then was validated that it is a type of tool that can be used to assess cholesteatoma. And also, importantly, with this paper, we could retrospectively apply the staging system to our data sets. But importantly, one of the important findings that was presented in the discussion section by Adrian and his colleagues was that there was a lack of correlation between the staging and the recurrence. In other words, one of the main purposes we're trying to achieve is to try and create a system which we can use to try and stage so that we can predict recurrence. And there were some flaws in the system. And subsequently, there's been quite a few papers actually testing the classification and coming to a very similar conclusion, that there's limited value in the staging to predict recurrence. The staging does have some value, but not in necessarily predicting recurrent disease. And so this quite nicely dovetails into the idea that the system or the classification did create a logical, categorical, and ordinal system, but its main defect was that it lacked correlation between the staging and the risk of recurrence when it was applied to various data sets. And so this began the more modern history of outcome collaboration and led to the International Otology Outcome Group that will be spoken about, I think, with the next couple of speakers. Thank you.
You're muted, Arun.
That is a very good talk about the classification itself, and then also the disappointing fact that whatever we classify is actually not turning it into a any use in predicting who's going to get a recurrence. So let's move on to the next talk by Manuela on the Samio-Atto classification.
Share my screen. Okay, can you see the screen?
Yes.
Okay, thank you, Aaron. So I will talk about the challenges of when reporting surgeries for cholesteatoma. So I'm not going to talk about the staging. I'm just going to talk about reporting surgeries. So, well, we know that when we want to report outcomes of cholesteatoma, as Nirmala has outlined, it's important to report, first of all, what is impacting the most is the type of cholesteatoma, whether it is a primary acquired, a secondary acquired, a congenital. You wouldn't probably want to report all of them in the same group because each of them have a different clinical behavior. And it's very important to report the disease extent, the severity, and that's why we need to find a consensus on a staging classification that helps us predict and report the outcome of recidivism, whether it's a recurrence separately and residual. But it's very important to really be very precise also in the description of a surgical approach. So we need to find a standardized parameter for a consistent description of our surgeries. If you look at the previous decades, most reports on outcomes of cholesteatoma were really about canal wall up versus canal wall down. But times have changed, and as you've seen in this current decade, more and more surgeons have adopted endoscopic techniques, whether are transcanal, totally endoscopic, exclusive endoscopic, or also combined with mastoidectomy. And also we can see now, as this talk this morning, how there's now the reintroduction of techniques that maybe were not used in the last decade, but before, and now we're using them again, such as mastoid obliteration techniques. So, again, the International Outcome Otology group is a collaboration of otologists that came together to try to come together with a consensus on methods of classifying the surgeries. And you can check out their website on IWGEES. And so in 2018, they proposed a classification framework to categorize tympanomastoid surgeries. And the acronym is SAMIO-ATO, where the first block of words, SAMIO is the framework to describe mastoid surgery, and the ATO is the framework to describe middle ear surgery. What is nice about a lot of really nice, I think, characteristics of this framework classification? Well, I think the first one is very intuitive, is that as you open the website and you can download these pictures, is that there is a figurative representation of the surgeries where every surgeon can intuitively see what surgery were we talking about, and I'll go over. And then let's look at a moment at the acronym at each word. So S stands for stage of surgery. And so you can categorize your surgery as either an S1, primary surgery, or S2, a planned second look surgery, or a revision, an unplanned surgery. Then it introduces, it also includes the possibility to categorize according to the approach. And so we see that this approach includes an endoscopic transcanal, a microscopic transcanal, an endoral, we don't want to forget the endoral approach, as well as a retroauricular. And then we have the categorization of mastoid surgeries. And so you can see in this picture, the MX would be just a transcanal operation that limits to the middle ear. But when we have, while we have M1A is a classic canal wall mastoidectomy, and M1B, it's a mastoidectomy with a facial recess approach, you can see from the drawing. And M2A would be, this is applicable, it can be done all ways. It can be, this is a scutum removal, an athecotomy. This has to be classified there where this was done endoscopic, microscopic, or endoral. So that's why you have to have this subclassification. You can have a scutum and a very wide athecotomy. This would be an inside-out mastoidectomy that also can be done totally transcanal or with a microscopic approach retroauricular. Then you have the M1A and M2A. It's a canal wall mastoidectomy associated with scutum. And then we have the M1B plus M2A. It's a mastoidectomy with scutum and facial recess. And then we already talked about the canal. The canal wall down probably doesn't show because I don't know, I see now the icons of the windows, but the M2C is a classic canal wall down. And M3A and M3B are a subtotal pretosectomy with a difference whether you are keeping the aortic capsule or the aortic capsule is removed, and you can see the overclosure of the canal. And then it also talks about, we can also subdivide your external canal wall reconstruction, where you reconstruct with soft materials such as fascia or perichondrium, or rigid material, whether you're utilizing cartilage, a bone calvarial graft. And then describe the obliteration of the mastoid, whether you have a partial obliteration limited only to the mastoid portion or your canal wall down, or a total tympanomastoid obliteration. When we talk about the ATO framework for middle ear surgery, it's a very helpful tool for the surgeons because, again, it's very intuitive with these pictures where the surgeon can help keeping a database describing what reconstruction was done. A is the access to the middle ear. It's basically you have all stages where you're doing a canaloplasty or a partial canaloplasty. T stands for the type of reconstruction you've done with the cartilage, whether you use complete partial cartilage grafting with cartilage or a total tympanic membrane reconstruction. So these are all very helpful when you add to a database. In the vesicular chain, you can see now you can really see very well whether you're doing, for instance, a type 3 tympanoplasty, that would be that OSD, TM directly on the stapes, or you're doing an interposition graft that can be from stapes capitulum to the incus, OSM, or from stapes capitulum directly to the tympanic membrane. Or it also applies for stapes surgery, because you see the last three follows, the last two pictures at the bottom on the left. So this database is also applied if you're looking at a database, for instance, on outcomes of otosclerosis. So this is very, very useful. Now, on a practical point of view, I can show you how, yes, I'm one of the surgeons that add a little bit extra minutes at the end of the day. I do, it's important when you do your progress note to take pictures of the cases. I don't, pre-surgical, I take a photo pre-surgery, I take a photo post-operatively, and I'm able with electronic medical record to upload the photo for recording. But also, I also, for the operative note, what it has helped me keeping a database and going back to years before my database is that I always dictate my own note. I don't let the resident dictate the note, because in the note, I want to add my findings, atomizing every single important. And then at the end of the case, I have my own little sketchbook where I do my drawings. This is something that I was doing since I was a resident and learning about septorhinoplasty. I always liked to draw. That helps me a lot to remember the case and in my mind what kind of reconstruction was done. And then we record all the videos. All the surgeries are video recorded, and the pictures are uploaded, the intraoperative pictures are uploaded in the chart. The videos are kept at the hospital. So if I have to do a second look surgery, I may go back and look at that surgery to kind of review a little bit what was done in the first planned surgery. So I also have a red cap that where I keep my database of my cholesteatoma. And so the last thing I want to share with you is that we have, as you can see on my red cap, I have adopted this IWGEES classification both for staging and surgeries. Now, the surgeries are many. So in the M, there is, 20 options. But in reality, I have to tell you that these are the options that I do in my surgery. And I don't know if you can see the two photos, because for me are, you probably just have to move. Yes, I can move photos. So these are the transcanal endoscopic, you can do a no mastoidectomy, only scutum removal, or as you can see, this is an example of a transcanal inside-out mastoidectomy. The canal wall up are, the canal wall up mastoidectomy can be intact canal wall with facial recess approach with scutum in the scutum, and the canal wall down mastoidectomy. This is an example. So when I'm looking at my outcomes, currently I'm looking at outcomes of primary cholesteatoma. I couldn't really look at outcomes for each of these 7 surgeries that are the 7 surgeries that basically I have looked at, because that would underpower the analysis, because we would have few of each. And so I have grouped them into 3 big groups. I'm looking at the transcanal, the T's. Second group includes the canal wall up, and third group is the canal wall down. And so that is a practical example of how I am recording my database. And that concludes my presentation. Thank you.
Thank you, Manuela, for that excellent description of how you record your outcomes. I think now we'll move on to Adrian, and he's going to talk about the recording outcomes and hopefully the REDCap database that he has created. So Adrian?
Yes, thank you, Arun. So just to put my talk in context, as was indicated in the previous session, in order for us to get reliable answers, reliable evidence to help us do our surgery better, I think there are 4 component parts. The first is that we record standardized data on the nature of the cholesteatoma, which Nirmal talked about. The second is that we have a standard system describing our surgeries to avoid the kind of confusions of nomenclature that Arun mentioned earlier, and that's what Manuela has just described. The third part is that we have standards for recording outcomes, which is what I'm going to talk about in a moment. And then the fourth part is that we have a method for collecting those data, which is the database that people have been talking to, and indeed seem to have expected that that's what I was going to be talking about. But I actually interpreted my remit slightly differently, Arun, and so my talk is actually about the third part is about standards for recording the outcomes, because I think this is a very important topic. And so I will give this talk, and then at the end I will just briefly describe how you can access or how you can create your own database that matches that of Arun's, Manuela's, Nirmal's and mine, so that we can all collect the same data in a standardized manner so that we can get better outcomes. This work that I'm going to present is the third part, is about recording outcomes. And just as Nirmal was saying that there was a consensus meeting for the staging system at the Edinburgh cholesteatoma meeting, we're hoping to have a consensus meeting at the cholesteatoma meeting in Shanghai, where we see if we can come up with the finalized standard that this talk is addressing. When it comes to outcomes, when I see my patients in clinic, there are two key outcomes that keep on, that the parents and the kids want to know the outcomes to. Is the cholesteatoma going to come back again? And will my hearing get better? They're very simple, obvious questions. And as good surgeons, they're the questions that we want to know the answers to from our surgeries as well. And but when you look into the questions, they're actually a bit more complicated than they first seem, because of course, as Nirmal emphasized, there are two different ways it can grow back. One is residual disease that was left behind, and the other is recurrent disease when a new one starts to grow again. And so it's very important that we distinguish these two in all of our record keeping, whether it's in the operative note or in our database, because the cause is different, how we prevent them is different, and how we detect them is different. So the first point is that when we're recording cholesteatoma outcomes, we need to specify whether the disease is recurrent or residual, or indeed whether it's uncertain. And you can imagine if you're doing a retrospective chart review, particularly you could argue if the notes have been dictated by trainees who might not be familiar with the difference, but indeed many staff surgeons, many publications confuse this difference, then you have to say that it's uncertain. You don't know whether it was residual or recurrent, you just knew it grew back. And it's also uncertain sometimes actually during the surgery, because the ear is such a mess, you can't really tell whether it was recurrent or residual disease. So those are the three categories that we need to acknowledge. When it comes to residual disease, rates of residual disease are going to depend on what methods we use to detect it. You can see here there's a little pearl of residual cholesteatoma on the anterior crus of the stapes, maybe 1.5 millimeters in diameter. Of course, that would not be visible with otoscopic follow-up in the clinic. Even if you didn't do a cartilage graft reconstruction, you wouldn't be able to see that through the eardrum. It would not show up on MRI on the non-echoplanar sequences because it's too small, it's less than a couple of millimeters. It might show up on CT, but really the only reliable way of finding it is with a second stage of surgery. So depending on which methods of these you use, you will or won't detect the disease. So as was described in this consensus document from Holland, it's very important when we're recording our outcomes that we specify the method of detection of the residual disease. And again, we need to say, so we can say, you know, that there's clearly cholesteatoma, there's clearly no cholesteatoma, or in many cases, it's uncertain. If you use a CT scan, you see some gray stuff. You don't know if it's cholesteatoma or not. Sometimes the non-echoplanar diffusion weighted imaging sequence is it's a little bit bright, but is it bright enough to be cholesteatoma? Don't know. We're going to do another scan next year and see. So important we record those different categories. But, and I think this is the most important thing I'm going to say all day, we talk about a recurrence rate. That means how many do we get per unit of time? Yeah, rate means something to do with, you have to have a unit of time when you're talking about a rate. And of course, the recurrence rate increases with time. So in the IWGEES study that we talked about before, 2% of adults overall had cholesteatoma, 9% of children overall out of those 1,400 patients. But it changes with time, doesn't it? At 1 year, or let's say 6 months, the rate was 0%. And then as time went by, the rate got higher and higher. So when you do a Kaplan-Meier survival analysis, you find that the adult rate was actually 5% at 5 years and 15% in children at 5 years. So these are very different numbers, aren't they? 2% or 5%, 9% or 15%. The reason they're different is because of incomplete follow-up. Some patients were done too recently, so they haven't got cholesteatoma yet, and some were lost to follow-up. And if you don't quite, if you're not sufficiently convinced by what I'm saying, you really should look up this article by Stangerup, who used different methods of reporting the recurrence rate and got really quite dramatic differences in the percentages according to the method that he used. So it should be mandatory that when we talk about cholesteatoma recurrence and probably also residual disease, that we use a survival analysis. Just imagine a cancer paper saying, oh, we had a recurrence rate of cancer at 5%. Well, it's meaningless, isn't it? Everybody talks about 5-year survival rates for cancer. We should be doing the same thing for cholesteatoma. And in order to do this, this talk was basically about how we record the data. So in order to do this, we need to record the time at the last follow-up of the patient. We need to record the time it took until we found residual disease and the time it took until we found recurrence. So that really is a fundamental part of the data that we record. If you want to know how to produce a nice looking and comprehensive Kaplan-Meier survival curve, this paper in the BMJ Open describes it very well. And if you're familiar with R, the free statistics package, you can download this code, which will very easily help you to produce appropriate Kaplan-Meier survival curves. So that's one part. The other part is the hearing. And this too, on the surface seems like an easy question. Will my hearing get better after surgery? But as you'll see, this also, how we answer that question gets difficult. And to make the point, here are two patients, patient A, patient B. Here are their preoperative audiograms and here are their postoperative audiograms. And you can see that the audiogram is better for patient A after surgery. The pure tone average is air conduction is just under 20 decibels, whereas this one was just under 30 decibels. But when I asked the patient, did you notice if your hearing got better after surgery? This one said there was no change. And this one said, oh yeah, my hearing's got better. So you also notice that the change in air-bone gap for this patient is more significant than the change in air-bone gap for this patient. And so which method we use is going to depend how we, what answer we get. We should probably be using patient-reported outcome measures. I'll talk about that in a moment. But when we use an audiogram, should we talk about the change in air-bone gap? Well, if you've got worse hearing to start with, you've got more potential for a good improvement in air-bone gap. But if you start off with normal hearing, you're going to get no change in your air-bone gap. So this isn't a very useful parameter, although it seems to be the standard in most publications. Really, air conduction threshold is the most important outcome. But then if you have some patients with presbycusis, it's going to lower your, make your outcomes look worse than they really are. This paper in the new Cochrane review suggests that we should be using the proportion of patients with normal hearing, the very good argument in this paper for why we should use this as our outcome measure. But then the question is what threshold is normal hearing? So we don't necessarily know what the best measure is to report here yet. When it comes to PROMs, there are several that are in many languages and have been validated. The one that I'll draw your attention to particularly is this one. It's specific to ears with otitis media, including cholesteatoma. So it's probably the most relevant to our question and has been translated into the most languages. So I think that this might be the one that has the wind behind it that we end up using. And it does have 3 questions that are kind of relevant to hearing. Pretty simple. You answer on a scale of 0 to 5 if you have hearing problems at home and if you have hearing problems in noisy environments. And does your ear impact on your daily activities? So this might be one that we end up accepting as a standard, but I'm not sure that we have a kind of validated answer to the question of what we should use as a PROM yet. So I think, though, that what we could agree is that it's important that we use a patient-reported outcome measure, and that when we use an audiogram, it's probably appropriate to use these time points as indicated by these old guidelines. You also have to specify the time point when you're writing it up. You don't just pick the best post-operative audiogram to make your results look as good as possible. You pick a standardized time point and use that one. Some of you be familiar with the more recent guidelines that are kind of more widely accepted in the US, which require a word recognition score. This isn't done much in kids and hasn't really been validated for conductive hearing loss. So I'm not sure that this is widely accepted, but many people would argue that that should be included. So to summarize what data we should be recording, very important, critical that we distinguish between residual and recurrent disease and say that the regrowth or the recidivism is of uncertain type if we can't tell. We need to talk about the detection method for residual disease. And most important, we need to use a survival analysis, which means recording the time to the event or the time to the latest follow-up so that we can answer our questions properly. And when it comes to hearing, do the audiogram at standardized time points. And probably we need to figure out which is the best patient-recorded outcome measure to use. That doesn't mean don't do it while we're figuring it out. I think we should be making a start on this. So there is a draft manuscript prepared for this outcome set from the International Otology Outcome Group. We will be talking about it at the Cholesteatoma meeting in Shanghai next month. If any of you would like to contribute to refining that, give your opinion on it, you're very welcome to contact me at this email address or through the IWGEE, which actually does come back to me anyway. And also, so that's the end of the talk about the outcome recording. But the other thing that people wanted me to talk about more was the database. And so just briefly, we do have freely available tools for the database on the IWGEE website, which is mentioned here, www.iwoge.net. The other speakers have already given examples of how they use that and shown screenshots of what it looks like. To try and make it easy, there are some automated tools to save time with entering the data, and there is an app available for iPhone and Android phones that plugs the data into your own REDCap database. So I actually enter all my data, as the others were saying, after the surgery on this app, which makes it pretty easy. Version 2 of the app is coming out soon, so it's not possible to download it at the moment. But if you contact me, then I can keep you informed, and you can share with people like Arun, Manuela, Nirmal, me, many others, to record a matching data set so that one day we can put those data together to give us better answers on how to advance care for people with cholesteatoma. Thank you.
Excellent, Adrian. Thank you very much. I know even though you think that you have deviated from the subject, actually it turned out for the better ones, because this is the thing that we want to hear. So regarding the REDCap, what I wanted to point out is that I had a lot of difficulty only because that almost everybody have access to some university REDCap. The only thing you have to do is anonymize your data totally by having an Excel file or something in your own hospital's computer and give just numerical numbers. And I got it in writing from my data protection agency in my hospital that I am okay to use that anywhere, as long as it is within the UK. So I got access in the Glasgow University. So almost everybody in the world will have access to REDCap in somewhere in the university, and then you will all be able to do it. And the main thing is think outside the box, and somehow the hospital, the data protection agency, it almost feels as if they're too worried about accepting anything new or allowing you to use the data anywhere else. So, but there are ways around. They're only there to protect you and to the public, so you can convince them. And if you do it in the right way, you will get there. So that's the good news. So I think this is since it's a panel discussion.
Can Can I just add to your point? Because there's one thing that causes people concern and confusion. The point about this IOG database is that the database is not held centrally. It's not held by the International Otology Outcome Group. People hold their own data in their old institution. And so that's why we get around these privacy laws. It's your database, you keep it, but because the data fields are the same as other people's, we can then, with the appropriate legal framework and ethical approval, we can then put those data sets together later on. So it's your database, but you can just record the same data as everyone else.
One other thing I want to point out, Adrian, is that one of the things, stumbling blocks again for me was that they don't want you to start anything new. That becomes a research. If you are doing it for every patient, it becomes a standard of care. Okay, as long as it is a standard of care, you don't need any permission, and you are keeping the data. Only you have access to it. No one else can access the data. And even if somebody in the university can have a look at it, they won't have a clue about which patient it belongs to. Even I won't have a clue. It will be only a number, patient number 79 or something. But since I started the database using the REDCap last year, I've managed to collect 80 patients prospectively, which is a great news. I'm still sad about losing my other patients from, my 10, 15 years worth of collection from Matthew's database, but I'm still, at least the original database is there, and I can add it to this by manually trawling through the data. But prospectively, going from last year, I've moved on to the REDCap. Okay, that is so we got about 80 participants, which are hardy participants remaining. I think 10 of them are faculty members, but the other 70 people are still there. I was worried that the moment you say outcomes, everybody is going to disappear, but it hasn't happened, which is a good news. So the future is bright. So I need to ask a few points. You told me about the one thing I will ask. What do you think is the single factor which is preventing people to collect the data? Is it the time constraints, or is it the lack of availability of facilities, or is it the fear of the outcomes being bad? What do you think, Adrian? What do you think?
My guess, because obviously I'm one of the people who do record the data, so I can't necessarily speak for those that don't. My thought is it's the time that it takes. And I think that the people who don't do it probably don't have sufficient interest to invest the time, or they're so busy with their work and other, the things on their time that it's just literally impossible for them to find the time to do it.
I think there's also another thing, Adrian. I work mainly in the public system, and there is some time allocated for me to do the paperwork. So, and I don't really claim or anything, but if those who are completely in the private system, for example, time is money. It will equate. So would you waste your time sitting there and enter the data? Unless you are very dedicated. But the other thing is that when you start doing this, it takes a long time. Okay, but it becomes a habit, and nowadays I can very quickly do it. I'm still not able to connect my app to the REDCap database. I don't know why, but when the new version comes, I hope that it will.
Try again.
Because when I enter the audiology data, that is the time. That is the point which takes a long time because I don't have the app. I'm waiting for the new app to come so that I will then try to sync that with my database. So I'll ask the same question to Manuela. What do you think is the stumbling block? You come from a slightly different sort of setup than mine. So you're muted.
I would say it's a combination of all three factors you mentioned. Sometimes it's hard to start halfway, where you have 15 years of great experience, but you never really recorded photographs. You let the residents operate, dictate the case. So it's really hard to go back. And so, like you said, you lost some of your data, but now you're going prospective. So there's it takes time, it takes commitment. It's hard sometimes to start and know that you kind of all the stuff that was done before, you didn't do it. So there's a little bit of that, but I think there's always a time to get started.
another point, all my data even before was prospective. It was all collected very prospectively. We even tried to invent a new app which will retrospectively download the data, and then I can continue adding more. But the problem was that then even if a small error in the coding will make it not usable. So we did try to make it, and one of my colleagues in Glasgow did make it, but I found out that after inputting all the new data, I was not able to download anything. So I don't want to waste my time. So that's why I moved on to the new one, but the previous ones are still there. So that is fine. Shall I ask the same question to Nirmal?
Not too many more insights. I think for me personally, it is a big time commitment. But I decided to start this when I started endoscopic ear surgery, and as soon as I heard of Adrian's red cap, I moved to that. And I must say, like you said, it becomes a habit eventually. And we're fortunate to have a fellow now. So we've habitually taught the fellow to enter the data prospectively. But I think the biggest hurdle for me is really also the audiology input.
Yes.
The problem.
I think with the new sort of, the app that Adrian is mentioning, if you can enter the data with a touch, previously Matthew's database was drop down boxes. So 50 or 20 or, whereas this one you have to type in, and if you make a mistake, instead of 15, it'll become 105, and then it becomes a problem. So that I have to take extra time to make sure that doesn't happen. So you mentioned one thing about the trainees. That brings nicely to the next question. Okay, do the trainees, when do they start monitoring their own outcome? Should they be responsible for monitoring the outcomes? If somebody is an otology trainee, or if they want to do otology, should we not be encouraging them to start the database early? And the other thing is that this database, it doesn't differentiate between a trainee doing 50% and then you doing 50%. That is one of the things that I struggle with. I still enter the data if I had something to do with it. But if it is completely done by a trainee, I sometimes find it difficult to enter that as my data. But I think we need to encourage the trainees right from the day they decided to become otologists, or they want to train in otology. Maybe they should start at least simple things like laryngoplasty audit. And it is mandatory in some countries to show an audit in New Zealand, for example, they have to produce an audit of 20 cases of laryngoplasty. So any thoughts, Adrian or Manuela?
I agree with you, Arun, that it would be good if it could become kind of part of regular practice. It would be good to get the trainees doing it as part of what we normally do. Still difficult with the time, though.
Just as a last point, time, when you mentioned time, it's nearly time to stop. So the last question, how long is a piece of string? How long is the follow-up that is enough for adults and children? You can answer that first before I ask others.
Well, I was going to ask earlier, actually, in the session, whether people who do cholesteatoma surgery in children find that they're getting recurrences, later on in adulthood when the patient's 30 or 50 or 70. Because my follow-up is lost at 18. So I basically follow all my patients till they're 18 and then refer them on to an adult person. And unfortunately, I rarely hear back from them about subsequent outcomes. So I think, kids, you need to follow them for at least 10 years. It's the same for congenital cholesteatoma. Congenital cholesteatomas get acquired cholesteatoma at the same rate as, other people get recurrences. So they all need follow-up. There are studies showing recurrent disease decades later. I'm thinking there was a study from Korea that talks about really long, decades-long follow-up. But my other thought is that, an adult patient, you can tell them to come back if they notice their hearing's got worse or if they've got an infection. So maybe it's not worth seeing them every year when they haven't had a problem. If you're clear for 10 years, maybe there's not much point coming back every year after that. I'm really interested to hear what the others say.
Okay, Manuela?
I think that 10 years is a really good number given all our experience. So I really press for patients to come every year. And as long as they come, I really appreciate to see, because we've seen adults that had surgery as a children, and they come up and there's been a gap of like 20 years where they were never seen. And then you see the problem rising, a problem that was slowly brewing without giving symptoms. As long as the patient allows me to see, I have not yet said, a patient with cholesteatoma, you are healed, don't need to come. I just tell them, come in a year. And then sometimes I notice, especially with the pandemic, they skipped a couple of years and then they got back on track. And, so maybe we had a little gap, but I would like to see them yearly, regardless.
Nirmal?
I'm always really disappointed at my follow-up because I think it's really difficult to get the patients to come back. I find once they have no pain, they're hearing reasonably, like a lot of things in life, you want to forget that health event. So you often ask patients if they've got any disease or any intercurrent health problems, and they say they're fine. And then you realize that they've had breast cancer 10 years ago and a heart attack 15 years before that, but they've forgotten about it because they want to move on with their life. And I think cholesteatoma is a much milder version of breast cancer and heart attacks. So I struggle to get people to come back every year. They just don't come. So when we look at our data, it's disappointing, but I would say often it's barely 50% we could follow up at 10 years. That would probably be a lot less than that, actually. Probably the best example of people who follow up really well are the Nordic countries, where the systems tend to be centralized in an academic center. But in Australia, it's very decentralized, so we can have the patient can go to almost anyone. So I struggle with follow-up a lot. The patients coming back.
The other thing, Nirmal, is that if they're insured or if they're self-pay, the insurance companies sometimes don't like them to come back after a certain number of times. And if they're paying for money, they have no problem. Why would they come back and pay you some money only to know that there's nothing wrong with them? Whereas in the NHS,
not just that, it's a time cost as well. Yeah, they have to take a half a day of work or something.
Exactly. So that is why in the NHS, luckily, we still are. Nobody has told me to stop, but I have stopped. I think the adults, nowadays I do a diffusion weighted MRI at the 5 years time. And then I tell them that if there's any problem, come back and see me. Children, I'll go for 10 years. For canal wall down, after 5 years, if they're asymptomatic, I started discharging them. And, and sometimes they attend the nurse treatment clinic for follow-up. But I don't always do MRI for the canal wall downs because they don't have any issues. But now, as everybody said, I'm doing more and more cavity obliteration. So there are a very small number of canal wall down in my practice anymore. So
I thought you were about to say you're doing more and more canal wall downs.
No.
Or an endoscopic.
Never. I'm doing combined approach, endoscopic, microscopic, and then cavity obliteration. That seems to be the standard practice. And regarding how much to go, I these days, what I do is I go in and look at the posterior area first, okay? That can be done very easily. And if it goes going into the antrum, then I know that it's not a very nice thing. So I just go and convert that operation by making a postauricular incision sooner rather than wasting time just looking at completely doing it endoscopically. So I think in the interest of time, I think I would like to stop, but it was a very interesting webinar, and thank you very much for contributing. And I must thank the International Working Group and also the Glasgow University for allowing me to convert this into a webinar. And one last thing, I'm recording this. So unless anybody has got any objections, I will download this and then maybe we can upload it to our IWGEES website. Okay, great. Thank you. See you soon, Nirmal.
Thank you, everyone.
Thank you, everyone.
Thank you, everybody. Bye-bye.